Good morning. I, Dr. Rajiv Sharda, on the behalf of Association of Colorectal Surgeons of India, Bhopal Surgeon Society, as well as from the Academy of Critical Care Medicine, Bhopal, I welcome all our distinguished guests, esteemed speakers, and dear colleagues. It is my absolute pleasure to welcome you all for this Colorectal Critical Care Conclave, a day dedicated to advancing our knowledge in the vital field of colorectal surgery and its critical care management. As we gather here today, we are united by our shared goals, improving patient outcomes by exploring the latest development, innovation, and best practices in colorectal critical care. The treatment of colorectal conditions presents a unique set of challenges, from infection management to post-surgical care. It is crucial for both surgeons as well as for intensivists to collaborate closely to navigate these complexities. This conclave has been meticulously designed to enhance our understanding, especially in addressing infection control and critical care management in patients undergoing colorectal procedures. Our agenda for today features an impressive lineup of expert speakers covering a wide array of topics essential for our practice. We are in for a rich learning experience. We also delve into important subjects like antibiotic prophylaxis, wound healing, and managing complex colorectal cases. Discussions that are critical to shaping our day-to-day practice in colorectal surgery. We are particularly excited about the panel discussion and interactive case capsules, which will offer us valuable opportunities to share our experience and engage in constructive dialogue. It is this exchange of ideas and expertise that will help us elevate the standards of care we deliver. As we embark on this one-day journey of learning, let us remember that the ultimate beneficiaries of our efforts are the patient who entrust us with their care. Every lesson learned today, every piece of knowledge gained, bring us one step closer to providing safe, more effective treatment for our patients. So thank you all for being here and for unwavering commitment to this cause. Now let us dive into what promises to be a day of knowledge, collaboration, and progress in colorectal critical care. So once again, I welcome all our speakers, chairpersons, distinguished guests for today's Colorectal Critical Care Conclave. And when I was planning with Dr. Santosh Bhaskar regarding this concept, because in the past I have never seen the colorectal surgeon, they are discussing about infection in colorectal surgery. So this is our initiative to have a dialogue amongst the intensivists on this platform. To make it more attractive, this academic event, today we have not incorporated the inauguration ceremony. We are not going to details about the chairpersons as well as the speakers because everybody knows each other. So this is our agenda. So let's hope what we can do for you. And now it's time, before we start our scientific event, now it's time to invite Dr. Bharti. Dr. Bharti is Professor, All India Institute of Medical Sciences, and she is going to be the organizing secretary of upcoming very prestigious Acrsi, Association of Colorectal Surgeons instructional course as well as the fellowship exams, which is going to be held in the month of April, first week of April from 2nd to 6th April. So she is going to tell us something about the instruction course and faculty exams. I know that so many postgraduates, those who have finished just their MS, they want to become the member of Acrsi as well as they want to give this examination. So I will request Dr. Bharti to please come on the stage and share his experience and how she is organizing the entire event. Dr. Bharti, please.
उनका presentation First of all, good morning to all of you. I thank Dr. Rajiv for giving me the stage for this. I'm just here for a few minutes because it's a very, very out of the box and a beautiful program which has been arranged. And so far, I had never heard about people talking on this particular aspect, whereas critical care, as we all know, is a very important facet of what anorectal and colorectal surgeons face. I'm just here for a few minutes to. Just a minute, there's this very small. Sorry for this, the initial teething problems, I believe. So I'm here basically to invite you on behalf of Acrsi, Bhopal Surgical Society, as well as AIIMS Bhopal. We are excited to invite you to a transformative instructional course in Bhopal, in the beautiful city of lakes, from April 2nd to 6th of April. This course is designated for aspiring fellows in colorectal surgery, offering a unique opportunity to enhance your skills and knowledge on this specialized field. Who all can participate is a question which is very commonly asked us. The course is of 3 days and can be attended by all surgeons who wish to enhance their knowledge in this field. The exams follow immediately after the course for 2 days are for those who aspire for the fellowship, and for them it is mandatory to be the members of Acrsi. Now this, all of you have been, since morning you have been seeing this standee, and I'm just trying to elaborate it for you all to make it a little more easy. Why should one become a member of the Association of Colon and Rectal Surgeons of India? We all know the magnitude of problems we face in the OPDs as well as in the OTs, and the various dilemmas any surgeon, any colorectal surgeon, be it a general surgeon or a specialized surgeon, has in managing a variety of colorectal problems. This particular society deals with a lot of things. One of them is they conduct well-structured instructional courses at conferences at discounted rates for those who are members, and they cover all aspects of colorectal proctology. And it can also, they also conduct various zonal programs, which is like our pioneer here are Dr. Nigam, Dr. D.U. Pathak here, sir, who are present here, and Dr. Rajiv Sharda, who has always been presenting a number of things which we all know him very well for. And it also has its own journal, this particular Acrsi. It has its own journals, and it also prescribes practice parameters and guidelines, which are easily available to those who are members, and it is there on the site. And it is also having a comprehensive Acrsi textbook, which is also put up again and again by Dr. Sharda. I have not got the picture of that, but it is available, and you have to contact Dr. Neeru, whose number is given here, and she will be able to provide this textbook. And this textbook is, there are so many textbooks on colorectal surgery, but this is a comprehensive textbook which will cover all the aspects which will be required for your clearing the exams or appearing for the course also. Then we have got yes, so it has the persons who clear their exams and become Acrsi fellows, they are also they can also avail domestic and international traveling fellowships to centers of excellence. Various centers of excellence have been selected. Plus, in addition, they also get affiliation to the as a member of the prestigious European Society of Coloproctology and also the American Society of Colon and Rectal Surgeons. They also give us access to their very, very prestigious journals, and this is an additional benefit of becoming a member of this society. I would request you all to try and think about it and become members of it here. Now, coming to the highlights of the course itself, which we are going to conduct shortly, the expert faculty are available, and you will get to learn from the renowned experts in colorectal surgery who will share their insights, techniques along with all the basics required. There are hands-on workshops in various fields, and you can have an opportunity to participate in interactive sessions and workshops that focus on the latest advancements and the best practices. There's also networking opportunities, like in all conferences you get this. Here you get to learn on the same platform with your colleagues who are fellow delegates and professionals, and you can build up valuable relationships within this surgical community. And of course, it's a wonderful cultural experience because of the scenic beauty and rich culture of Bhopal itself. Now, just to give you a glimpse here, there's a short video which I wish you all to be So we all welcome you to AIIMS Bhopal, and this is the venue for the 28th Acrsi instructional course. It's a newly built lecture theatre in our institute which caters to around 200 candidates. Just adjacent to this hall, lecture hall, is the dining hall. So there is not a very long place, a long distance you have to travel to come to the refreshments. And of course, our state is famous for these tigers. And for those who are coming from outside of the state, will have an eye-to-eye contact with them, because we have this one vihar where you can see them being fed, see them strolling around, plus of course the city of lakes. It welcomes you. And I wind up with an invitation to join us for this enriching experience that promises to elevate your expertise in colorectal surgery. We look forward to welcoming you at Bhopal. And these are the details which I'll be sending over to you, which is there also on this standee. And once again, I thank you all. Thank you, sir.
Thank you, Dr. Bharti, for the information regarding the upcoming 28th instructional course as well as this fellowship examination. I will request Dr. D.U. Pathak. Dr. D.U. Pathak just arrived from the Jabalpur for this conclave to present a memento to Dr. Bharti. And I am happy to share that the Dr. Nigam has written a very beautiful book on proctology, and will like to give this book to Dr. Bharti as a memento. Dr. D.U., please. Actually, she wants a signature from Dr. S.K. Nigam. Yeah. Sir, on the dais, please. Yes. Thank you, Dr. Bharti. Meanwhile, I will request Dr. Saurabh Chakravarti. Dr. Saurabh Chakravarti is a microbiologist and working in a corporate hospital, and he is exclusively working on the infection. He is a consultant in infection disease, and he is going to share us something about the microbiology essential for colorectal surgeons, and he has prepared a PowerPoint presentation on case-based study. To chair the session, I will request Dr. Bharti Pandya, Professor AIIMS, Dr. Navneet Mishra, Professor, LN Medical College. Dr. Anuradha Chaudhary, she is Associate Professor in Department of Surgery, Gandhi Medical College, as well as Dr. Rajesh Sood. He is consultant in Department of Surgery in a corporate hospital. Please take the seats. And Dr. Saurabh. For further proceeding, I will like to hand over the mic to chairperson. Dr. Saurabh, please, meanwhile.
Okay. Dr. Saurabh. Hello. Dr. Saurabh, you can start your talk on infection intelligence.
Thank you, Acrsi, respected chairperson, and Critical Care Society for giving me this opportunity. So, I am working, I have done my MD Microbiology and PDCC Infectious Disease from Hinduja Hospital, and now I am working as a consultant microbiologist and IT specialist in Bansal, Bhopal. So, my topic is infection intelligence, microbiological aspect for colorectal surgeons. Now the thing is, I have laid out my talk case-based discussion. It's not like that this is the GI flora, this and that. That is very boring. We can learn going through cases. So for colorectal surgeons, something is called surgical site infection, some are surgical infections, something like perforation, many aspects are there. Initially, I have given some brief highlights about surgical site infection. These are the infection within 30 days, or if there is implant within 90 days of procedure. Surgical site infection is 38% of the nosocomial infections are SSI. Incidence rate varies from Indian data is 5 to 30%. This is the most common cause for unplanned admission post-surgery. Increase for surgical site infection, it increases morbidity, mortality, aging population, complex surgeries. All these are causes of rising of incidence. Now, definition for surgical site infection, it's like purulent exudate from surgical site, positive culture from surgical site. If there is any clinical sign and the wound, if it is re-explode, that is definitely a surgical site infection, and surgeon's diagnosis. Now the thing is, if there is serosanguinous discharge, one superficial swab is collected that grew some of the organism like Candida, any of the cons, is that a surgical site infection? No, probably not. So that is something like one-to-one case-based discussion we have to do. As per definition, that is as SSI, but by and large, that is not an surgical site infection. So microbiology for a surgical site infection, if it is a clean procedure, most common organism are the skin flora, Streptococcus, Staphylococcus aureus, or coagulase negative Staphylococcus. If it is clean contaminated surgery, again the skin flora covering Strepto, Staph and cons, along with that gram negative rods like E. coli, Klebsiella, Enterobacter, anything, and Enterococci. These are the organisms. If it involves any organ space, then it is polymicrobial. Again, E. coli, Klebsiella, Enterobacter, Enterococcus, anaerobes, bacteroides, even Candida. So, in recent trends, even in India, MRI is gaining its popularity. Data from Bansal Hospital, mainly from plastic surgery department, in a month I have reported probably 17 MRSA. So MRSA is gaining very popularity in post-surgical scenario. So higher mortality, longer hospital stay, again and again readmission, all these are the problems. And along with that, for MRSA, it's challenging to manage because there is every MRSA drug is having its own PKPD, own specialty. So choosing a drug is very tricky for MRSA infection. Even Candida species on rise, and it is mostly exogenous source of infection. Among those 17, one case I remember where the source of infection is endogenous, that patient's right groin was colonized with MRSA. Rest of the 16 cases, we routinely do MRSA surveillance. If any patient reported MRSA, so we do definitely do nasal, axilla and groin swab surveillance. Out of 17, one case I remember where groin was colonized. Now surgical infection is something where for treatment of that patient surgery is required. That is not like after surgery this infection developed. For the infection the surgery was done. That is surgical infection. Like all those are mucormycosis, any abscess, any emphysematous disease in viscera, all those are surgical infection. So we move on to our case discussion. Sir, मैं सामने आ जाऊँ, मुझे दिख नहीं रहा. Hello. This is a. No, this is okay, sir. This is a 49-year-old male post-bariatric surgery. Repeated intra-abdominal collection. 2 times the collection was drained. Every time there is no growth in culture sensitivity. This is the repeated report. Patient received meropenem, linezolid, faropenem on and off. Same episode continued for 1.5 months. So we are having a patient who is having post-bariatric surgery, repeated collection every time, no growth, multiple gram-positive, gram-negative, everything she has received. Now the patient came to us, how we can plan management of this patient. So this patient admitted, this time with high-grade fever. Every time there is collection, low-grade fever, but this time high-grade fever. Along with that, burning micturition, and this patient actually of my fellowship days, and patient to referred to infectious disease department. CT abdomen was done with oral and IV contrast, and there is collection. Size of the collection is more than 5 centimeter. There are probably I mentioned 2. There are 4-5 collection. The largest one is 5.5 into 5.3. That is more than 5 centimeters collection is there, communicating to each other, and there is secondary perilesional fat standing. So we have planned, because the patient have received multiple antibiotics, immediately draining the collection and sending the collection to for microbiological evaluation for getting something, what antibiotic to give. It is of no use, because last 2 times what we have seen, 2 times there was no growth, because already antibiotic effect is there. So we have planned an interval of 1 week, despite the patient is having fever, but hemodynamically stable. We have sent the patient home. We have asked the patient to get readmit after 7 days. 7 days usually for meropenem, it is being said that 4 times of the half-life is the duration when the drug gets eliminated from body. So if we consider 1 day is half-life for meropenem, so at least 4 days interval is required. We have planned like 7 days interval, and then the patient, that abscess was drained, and abscess was bedside, inoculated in blood culture bottle for growth enhancement. Now what are the possible list of organisms for this patient? This is a post-bariatric surgery, so most likely all the GI flora can be involved here. GNB, GPC, anaerobes. But why I have mentioned fungi, TB or NTM? Because multiple times this patient abscess was tapped. So any of the probe can be contaminated with NTM, MTB, anything could be the possibility now. Initially maybe it started with GNB, GPC or anaerobes. So what we have suggested, that send a gram stain, calculiferous stain for fungi, AFB stain, aerobic culture, fungal culture, Gene Expert Ultra, and midget culture as well as NTM midget culture. So in gram stain, what we received report is moderate number of pus cells, few gram positive cocci in chain, and gram negative bacilli. What we have discussed, few gram negative bacilli, anything could be E. coli, Klebsiella, Enterobacter, and from gram positive cocci in chain is suggestive of Streptococcus or anaerobic Streptococcus, mainly GI flora. So these are the possible organisms. Now what antibiotic we can start empirically? Piptas, meropenem, tigecycline, ticoplanin. So Piptas, meropenem and tigecycline about GNB, for empiric coverage is okay. The ticoplanin is having no gram negative coverage. About Streptococcus, penicillin or meropenem or cephalosporin may cover, may not cover. No one can say till the antibiotic sensitivity we receive in our hand. So peptides or marrow or tico can cover all the isolate in soft tissue as well as in blood. You can see tigecycline can cover GNB and strepto both, but we have not selected this because we don't know yet that the infection is limited to soft tissue only or it is in blood all, because patient is having high grade fever. So tigecycline is having rapid tissue distribution. Standard dose tigecycline is not therapy of choice for gram negative infection. So tigecycline was avoided and we have started with peptides and ticoplanin. Now this picture is very hazy. Actually there are two organisms that was isolated. One is pointer hai kya? You can see this Burkholderia capacea. This is a hospital acquired infection. It can't be endogenous flora. So what we have suspected, anything from outside could be there, that is get proven because Burkholderia capacea from repeated tapping somehow at some point of time got introduced. Fortunately this patient is having many options for treatment. Nowadays in Bansal hospital, Burkholderia usually the sensitivity comes pan resistant. We have to routinely use colistin with ceftazidime ibipectin, but this patient is fortunate enough, he is having multiple options here. And Streptococcus sanguinus is the second bug. This is gut related. So what antibiotic to continue? Till now the patient is getting peptides and ticoplanin. So now it's time for we have to de-escalate as well as plan for discharge. Patient is having collection, that collection was drained, patient is stable now. So maybe longer therapy required because collection is was around 5 centimeter, that is drained. For now oral antibiotic, what are the options? We can go to previous slide. We can see one is the option is cotrimoxazole, ceftazidime. Among oral options, levofloxacin. So cotrimoxazole and levofloxacin, these two are the options for Burkholderia, and for Streptococcus this is mostly pan sensitive. That is the thing, patient may need longer therapy, so oral option is preferred, and it is preferred that cidal drug is preferred over the static drugs. So the patient was discharged on Septran DS 1 tablet BD and simple capsule amoxicillin 500 4 times a day. Here the question is why amoxicillin is given 4 gram? Because for Streptococcus 2 gram amoxicillin is enough. Why you have given 4 gram? Issue is we have the sensitivity we have received is of Streptococcus, but in stain there is mentioned something that GPC in pair that haunts like that gives hints for Enterococcus. Maybe Enterococcus is there. For Enterococcus, the standard dose is 4 gram. So you have given Septran DS along with amoxicillin 4 gram. I have mentioned that why you have given higher dose. So take home message, source control is most important for response. Bug and drug combination needs optimization. For optimizing this bug and drug combination, we need to know the bug, we need the sensitivity properly. So antibiotic free interval, long incubation, inoculation in blood culture bottle, bedside, gram stain, everything should be contributed. It is not like tapping the fluid and sending to microbiology and microbiologists will do everything. That is not the scenario. We have to plan before the procedure. Now case 2. This is a 47-year-old male, uncontrolled diabetic, history of anal fissure, acute onset perianal swelling, pain, fever, progress to formation of pus point. Outside consultation, superficial swab culture was done. In that Candida albicans, this is a perianal region that swab was collected and Candida albicans grew. Patient received amoxiclav and fluconazole, but patient did not get any response. Now the patient admitted in Bansal hospital. What could be the causative organism and empiric antibiotic of choice? We know at this point of time patient got no response with amoxiclav. So this is the entire list of antibiotic as the patient is admitted. So we can opt for injectable, peptides, cefoperazone, sulbactam, mero, tigi, septran, tico, fluconazole. These are the options. So for E. coli, Klebsiella enterobacter, this is perianal region. So possibly this is a polymicrobial infection covering GNV, GPC, even Candida could be the possibility. And patient is diabetic. So E. coli, Klebsiella enterobacter, all these drugs could cover, because peptides I have put for E. coli query, because amoxiclav patient did not responded. So maybe peptides is not a good choice here. So I have put some queries, but these are the panel. Now Enterococcus, penicillin or cephalosporin will cover if the isolate is penicillin sensitive. And for bacteroides, overall the scenario, tigecycline can cover everything except Candida. But the issue is, for a simple infection, say soft tissue infection, firing tigecycline is also not a good choice. Patient had high grade fever, but patient was hemodynamically stable. So what we have seen, that tigecycline can cover everything. Is it necessary to start empiric antibiotic? We have not started any antibiotic till we are getting evidence. How long antibiotic free interval required? Patient receive amoxiclav outside, we have planned for a day. It did not respond to amoxiclav, so is it a resistant bug to amoxiclav? Maybe or may not be, because we can't say that this is amoxiclav resistant bug, because source control was also not done. Without doing source control, amoxiclav, even if it is sensitive, will not work. So the abscess was drained, intra pus sent from OT, sent for gram stain and culture. These are the things we have seen in our gram stain. From OT to lab and seeing this bug takes half an hour. So we know this is simple Enterococcus infection only with gram stain. Now the question is, only based on gram stain, shall we start something like linezolid? Probably no, because this patient is diabetic. We are getting some evidence. That doesn't mean this is the sole cause of infection. So we should wait for the culture report as well. Gram stain GPC in pair, that is suggestive of Enterococcus, and in culture pure colony of Klebsiella grew. Now the thing is it necessary to do the gram stain? It is important, because in culture, when gram negative something is growing, it is impossible for a microbiologist to pick up the gram positive one. It is the stain that helped me. So both is contributory. So this is a very faint picture actually. You can see this is enterophysium and this one is penicillin sensitive. And this one is E. coli. This is a ESBL E. coli. Again, Septran is sensitive. Septran is very good for soft tissue infection and sidal as well. So again, the antibiotic combination we have used here is, now how to choose the antibiotic? It should be cheap, it should be oral, good bioavailability, good tolerance, less drug interaction, preferably bactericidal. So again, E. coli and Enterococcus. What are the oral option? Amoxicillin, minocycline, Septran, linezolid. When oral option is available, so IV option I have not put in the chart. So E. coli, amoxicillin is resistant, minocycline we have not tested, Septran is the option, linezolid again not tested for, not in panel of E. coli. Overall the scenario is Septran with amoxicillin can cover both the isolate. And accordingly the patient, this patient also 500 milligram, this is the dose of Enterococcus infection for, or dose of amoxicillin. Take home message, gives a clear idea about possible organism responsible depending on site of infection. Superficial swab culture need to be avoided to avoid detection of surface colonization. We can remember initially this patient is having a swab culture of Candida albicans. That is justified. Perianal region somehow Candida will colonize. But this kind of sample should be avoided. Every culture need to be accompanied by gram stain, AST of all pathogen required for narrowing down antibiotic required and optimizing clinical outcome. So now case 3. This is 37-year-old male admitted in general ward with complaint of left hypochondriac pain, low-grade fever for approximately 1 month under physician. Patient was treated elsewhere. Patient started on injection ceftriaxone 1 gram BD, and this time Dr. Ashok Gupta referred this patient to me. CT scan abdomen was done. In that more than 5 cm collection was there in spleen. Possible organism again This splenic abscess, that time I didn't know that why this abscess developed, as because I am not able to get any predisposing factor. Initially GNB, entero, candida, any mold, anaerobe, everything was in DD. Again tigecycline was added for GNB and enterococcus. Now how to approach this patient? Because that patient was not ready at that point of time for draining the abscess. We have given option, just drain the abscess, we will gather information, accordingly we will treat. But the patient was like, नहीं medicine से ठीक कीजिए, पहले medicine से try करते, बाद में देखते. So we have reviewed the past history. Every past history, past document is very important. While going through his past documents, one report I found, that was a 1.5 months back, patient was having a Widal positive of 1:320. That time I asked, पूरा ट्रीटमेंट लिए थे क्या, और कितने दिन का ट्रीटमेंट लिए थे? तो बताया 7 दिन लिया, फीवर चला गया, मैंने बंद कर दिया. तो रिसीव इनएडिक्वेट डोजिंग, अगेन पूछा कि कितना दवाई लेते थे? 3 गोली. दैट मीन्स मोस्टली सेफिक्जिम लिया होगा, approximately 7 days for a 70 kg person. Cefixime 600 milligram 7 days is severe underdosing, inappropriate dosing for cefixime. So possibly that time I made a provisional diagnosis, possibly this is a typhoid abscess. So how to approach this patient now? Antibiotic or antibiotic with surgical intervention or only surgical intervention. More than 5 centimeter abscess is there, सीधा स्प्लीनेक्टॉमी का ऑप्शन दे दिया जाए या एंटीबायोटिक से ठीक हो सकता है. सो दिस इज अ वेरी मतलब डिफिकल्ट कॉल. Uniocular abscess, that is a unilocular abscess, if drained with sufficient antibiotic, this is this abscess is a 5.5 centimeter, marginally more than 5 centimeter. तो I have discussed with Dr. Ashok Gupta that शायद एक बार ट्रायल देते हैं, एंटीबायोटिक कवरेज देते हैं, ड्रेन करते, फिर वेट करते, रिलैप्स अगर होता है देन स्प्लेनेक्टोमी कैन बी प्लान्ड. सो टू कंटिन्यू tigecycline or any change of antibiotic can be planned at this point, because this patient was suboptimally treated for typhoid. Patient developed abscess. How can we prove? Last last Widal titer was 1:320. अगर ये ठीक से ट्रीट नहीं हुआ रहेगा, that titer will be shows some increasing trend, that is justified. So we have repeated Widal test and this time it is more than 1:640. उसके आगे और हमने टेस्ट ही नहीं किया. तो हमको जो चाहिए था 1:320 से ज़्यादा, we have got more than 1:640. So very likely typhoid abscess, dose of ceftriaxone increased to 2 gram BD, tigecycline was stopped, CT guided aspiration was done and bedside that pus was inoculated in blood culture bottle. Already received ceftriaxone, so the drained abscess was inoculated in blood culture bottle and one part of that was sent for gram stain. Day 4 of incubation, aspirated pus grew some GNVs and final IDAST was Salmonella typhi. So message is, if we have not inoculated that in blood culture bottle or we have not incubated till 4 days, बहुत सारे पेशेंट लड़ने आ जाते हैं, बहुत सारे लैब 2 दिन में रिपोर्ट दे देते हैं, आप 5 दिन 7 दिन लगा देते हो. यही जैसे इसका फाइनल रिपोर्ट 6 दिन में हुआ था. तो लॉन्गर इंक्यूबेशन, that is the dictum. When there is antibiotic exposure, you know something is there, don't discard within 24 hours 48 hours. Ask the microbiologist, इसको incubate करते रहो जब तक ना satisfied हो जाओ. For orthopedic any implant I incubate till 14 days. मतलब काम बहुत डिफिकल्ट हो जाता है. डेली 80 के प्लेट के हिसाब से 14 डेज मतलब डेली 900,000 प्लेट देखना इजी काम नहीं है. बट दैट इज द थिंग दैट हेल्प द पेशेंट. We have inoculated and after 4th day of incubation we got this bug. Take home message: history, old treatment record is valuable for narrowing down diagnosis. Gram stain has important role. Culture report, if you are getting some flat report like no growth is of no use when abscess is there, आपको लैब में बात करना है, कुछ तो निकाल के दो. एब्सेस है, पस है, कुछ तो होगा, तो निकालना उनका जिम्मेदारी है. क्लोज कॉन्टैक्ट विथ माइक्रोबायोलॉजी लैब. क्लोज कॉन्टैक्ट मतलब डिस्कशन विथ माइक्रोबायोलॉजी लैब, हाउ द यील्ड कैन बी ऑप्टिमाइज्ड. टेस्ट मोड, ट्रीट ऑप्टिमली. नाउ केस 4. This patient is admitted at present in Mansar, lap appendectomy done somewhere else. developed anterior abdominal wall abscess. CT abdomen showed some abscess and tract within anterior abdominal wall. Earlier pus culture was negative 3 times. Pus aspirated, so this patient is admitted under surgeon, and we have aspirated the pus. You can see from this side. This was the point. I have put a syringe here without needle. I have superficially cleaned the site and aspirated some amount of pus from here, inoculated in blood culture bottle again, and kept for prolonged incubation. Finally, probably after 4th or 5th day, in blood culture something like this grew. What? This is something looking like GPV, very peculiar structure. Most of the lab you will get a report, this is contamination grown, some contamination is there, or you will get a report of these things. These are some GPCs, कुछ streptococcus, staphylococcus कुछ तो मिल जाएगा. But everybody will ignore this part. This is the most important part. ये growth आने में बहुत time लगने वाला है. This is something like this. This is AFB. So from a surgical site infection, repeated and lap appendicectomy, बार बार उसको intervention किया गया, पहले से ही लग रहा था ये NTM होना चाहिए, and we have got this. So अभी तक हम लोग इधर तक ही पहुँचे हैं. ये इस पेशेंट का आगे का जो ये सा वर्कअप है, दिस इज ऑफ अ डिफरेंट पेशेंट. जस्ट फॉर द सेक ऑफ अंडरस्टैंडिंग आई हैव पुट दिस स्लाइड. वी हैव डिटेक्टेड दैट द पेशेंट इज हैविंग NTM इन्फेक्शन. क्या इन्फेक्शन है अभी मुझे मालूम नहीं है. विल सेंड फॉर माल्डिटॉफ 2 एम्स, विल सेंड फॉर सेंसिटाइटर बाई ब्रॉथ माइक्रोडाइल्यूशन फॉर सेंसिटिव, एवरीथिंग विल डू. बट यूजुअली व्हाट वी डू, अगर मुझे इससे कॉलोनी मिल जाता है, विल सेंड द सैंपल फॉर LPA, स्ट्रेट अवे LPA. And in LPA, for this patient, like microbiota abscessus was detected, let's see it is abscessus or fortuitum, any rapid grower. Accordingly, the patient can be treated. So again, take home message, post-operative infection, surgical and post-operative infection are common and require very meticulous workup and treatment. Repeated negative culture need consideration about some atypical pathogen. जब 2-3 बार नेगेटिव आ रहा है, बैक्टीरियल से पेशेंट सेप्सिस में नहीं है, तो एक बार कुछ तो मतलब मोल्ड टाइप का इन्फेक्शन या NTM कुछ तो अलग सोचना है. बार बार नेगेटिव आ रहा है, कल्चर कराते हैं, दैट इज ऑफ नो वैल्यू. लास्ट केस. नाउ केस 5, 35-year old male, gangrenous cholecystitis, operated elsewhere, shifted to Bansal Hospital in shock. WBC 32,000, creatinine 5.2, on ventilator, X-ray में patches था, drain in situ, there one pictal drain is there, chest X-ray में bilateral patches है. So what are the possibility? So briefly कुछ intra-abdominal infection शुरू हुआ था, कहीं पे काफ़ी दिन तक एडमिट रहा, पेशेंट सेप्सिस में चला गया, अब ये पेशेंट शिफ्ट हुआ. तो ये दिस इज समथिंग लाइक इनिशियली स्टार्टेड विद इंट्रा-एब्डोमिनल इन्फेक्शन. नाउ इट कुड बी एनीथिंग बिकॉज सेंट्रल लाइन कुछ दिन रह चुका है, फोलिस रह चुका है. सो एनीथिंग पॉसिबल, न्यूमोनिया, UTI, SSI, ब्लड स्ट्रीम इन्फेक्शन, एनीथिंग कुड बी पॉसिबल. So what are the sample we can we have to send for investigation immediately? Urine RM, gram culture. Why gram? How these things helps every step. How why gram is important? Because one thing is stat. आपका माइक्रोबायोलॉजी डिपार्टमेंट, आप जिसके साथ भी बातचीत करते हो उनके साथ बातचीत कीजिए. अगर हम सैंपल भेजते हैं 1 घंटे में मुझे ग्राम दे सकते हो क्या? 1 घंटे के अंदर आपको बहुत सारी चीज़ें पता चल सकता है. एम्पेरिक चीज़ ही खत्म हो जाएगा धीरे धीरे. सो यूरिन RM ग्राम कल्चर, ET ग्राम कल्चर, ड्रेन साइड ग्राम कल्चर. क्या होता है इन एवरी स्टेप इफ़ वी गेटिंग सम कॉमन, यूजुअली क्या होता है ऐसे कॉम्प्लिकेटेड केसेस में वी स्टार्ट विद मेरोटिको, और हीमोडाइनमिकली अनस्टेबल है कोलिस्टिन मेरोटिको, दैट इज़ अ स्टैंडर्ड प्रैक्टिस. अब अगर ये तीनों साइड में GN भी दिखे तो टीको पार्ट ड्रॉप कर सकते हैं. ये तीनों साइड में हमको GPC दिखे तो कोलिस्टिन मेरा अवॉइड कर सकते हैं. तो इन एवरी स्टेप ग्राम इज़ वेरी इंपॉर्टेंट. Now empiric antibiotic of choice, it started with again just summarizing, started with intra-abdominal infection. Some days patient stayed outside somewhere with central line, Foley's, ventilated, chest X-ray में patches भी आ चुका है. At this point patient is shifted, patient is in shock. So what should be the empiric antibiotic choice? कोलिस्टीन टिकीसाइक्लिन फ्लुकोनाजोल, कोलिस्टीन मेरोपेनम टिकीसाइक्लिन, पॉलीबी टिकीसाइक्लिन फ्लुकोनाजोल, पॉलीबी मेरोपेनम टिकीसाइक्लिन, कोलिस्टीन मेरो टिकोफ्लुकोनाजोल, पॉलीबी मेरो टिकोफ्लुकोनाजोल. Again we just summarize. इस पॉइंट पे हमको स्टार्ट करना ज़रूरी है क्या, या हम थोड़ा और वेट कर लेते ग्राम स्टेन का? कर सकते, 1 घंटे के अंदर अगर आ जाए तो वी कैन वेट फॉर 1 आवर, बिकॉज इफ वी स्टार्ट कोलिस्टीन टिकीसाइक्लिन एंड फ्लुकोनाजोल, प्रॉब्लम इज इंट्राब्डोमिनल वेरी गुड कवरेज. टिकीसाइक्लिन with standard dose, there is no bloodstream coverage. IDSA recommends double dose tigecycline. Double dose tigecycline having notorious GI side effect, so routinely use करना is not a very good idea. Then colistin meropenem tigecycline, there is no gram positive coverage. Tigecycline can cover gram positive, but in intra-abdominal side, no coverage in blood. Patient is having shock, so ऐसा कुछ combination बनाना है that covers blood. Main is blood at this point. Polyb tigecycline fluconazole, again the same thing, tigecycline blood में नहीं रहेगा, only polyb and fluconazole. Polyb मेरो टिगी, same problem जो इधर था. Polyb मेरो will cover GNB, blood uncovered GPC. Colistin मेरो टिको fluconazole, polyb मेरो टिको fluconazole. Any of these two combination could be opted, जहाँ पे optimize soft tissue, blood and everything is covered starting from GNB, GPC, anaerobe, candida. Everything is covered in these two. Every combination has its own merits and demerits, so needs discussion for choosing the antibiotic combination. Now coming to gram stain, ET many pus cell but no organism visible. Right HD cat, GPC is pair, GPC in pair, drain site fluid, you can see here. This is core microbiology, आप लोगों को इंटरेस्ट नहीं आएगा, but just for the sake of understanding. ये देखिए, here we can see enterococcus, drain site में, you can see a short thick GNB. तो क्या कॉम्बिनेशन बन रहा है? क्लेप्शियला एंटेरोकोकस, ठीक है. उसके अगले दिन ये फ्लैग किया, देखिए एंटेरोकोकस क्लेप्शियला, जो मैं इधर 1 घंटे में बताया था वही चीज़ अगले दिन आ रहा है ब्लड में. तो विदिन 1 घंटे, विदिन 1 आवर वी कैन ऑप्टिमाइज, वी कैन डिटेक्ट मेनी थिंग इफ योर माइक्रोबायोलॉजी सपोर्ट इज़ वेरी गुड. सो इज इट ओके टू कंटिन्यू टिकोप्लानिन, क्योंकि पेशेंट तो बाहर टिकोप्लानिन मिल चुका है, हमको पता है एंटेरोकोकस है, तो हमको थोड़ा हायर अप जाना चाहिए क्या इस पॉइंट में, लाइक डैप्टोमाइसिन चला गया या क्विनोप्रिस्टिन, डैल्फोप्रिस्टिन, कुछ भी ऐसे कॉम्बिनेशन. सो ब्लड कल्चर में क्या आया? जीपीसी इन पेयर, दैट इज सजेस्टिव ऑफ एंटेरोकोकस अलॉन्ग विथ क्लेप्शियला. तो हम 1 घंटे के अंदर कैसे और इन्फॉर्मेशन गैदर कर सकते हैं, क्योंकि कल्चर जितना भी हम जल्दी करो 1 दिन तो लगने वाला है. सो व्हाट वी कैन डू इज some taking help of some molecular diagnostic, simply molecular diagnostic, and 1 day stay with empiric this much antibiotic will cost around 15, 20 or 30,000 maybe, versus some molecular test. Anytime molecular test should be preferred, जो एंटीबायोटिकल स्टुअर्डशिप में भी हेल्प करता है और पेशेंट के कॉस्टिंग भी इसका असर रहता है, मतलब कॉस्टिंग भी काफ़ी कम रहता है. वन सेप्सिस लो, बंसल हॉस्पिटल इज हैविंग दिस इंस्ट्रूमेंट दैट कॉस्ट अराउंड 3800. BCID पैनल, this is a bioMerio, this one cost around 8,000. So little higher up from this value, you can say this is CPT from company. So what we can have in that panels, we can have ID of the bug, we can have van A, van B, mic A, mic B. van A, van B रहा मतलब टिको तक हम नहीं देंगे, उसके ऊपर जाएंगे. mic A, mic B रहा, mic A, mic E रहा, तो मतलब ये MRS है, हमको टिको में ही रहना है, उसके नीचे क्लिंडाइन वगैरह देखे कोई फ़ायदा नहीं है. तो इतना तक हमको पता चल सकता है. अगेन फ्रॉम GNB साइड, इफ़ इट इज़ NDM तो हमको पता है कि हमको कोलिस्टिन देना है. अगर हमको इधर NDM, ऑक्सा 48, ऑक्सा 23, ऑक्सा 51 कुछ भी नहीं मिला, तो मुझे पता है मेरो के नीचे पिप टेस्ट से भी मेरा काम बन जाएगा. तो लाइक दैट विदिन 1 आवर वी कैन गैदर मोर इन्फॉर्मेशन एंड नैरो डाउन एंटीबायोटिक मोड. So finally ये पेशेंट को you can see Enterococcus faecium, this is the ID. what we have discussed before, patient को तो बाहर भी टीको मिला हुआ था, and see, टीको वैंको दोनों resistant है. Now only option is linezolid and tigecycline. This one involves blood as well as soft tissue. Soft tissue primary site of infection जहाँ से blood में आ चुका है, तो will we go with tigecycline or double dose tigecycline? Antibiotic options. आपको वाइटेक के स्टैंडर्ड पैनल में कोई भी लैब से कराइएगा, आपको इतना ही मिलेगा. ये स्टैंडर्ड वाइटेक पैनल है या बीडी पैनल जो भी है, इतना ही एंटीबायोटिक रहता है उसमें. सो if you go to Mandel book of infectious disease, it is very clearly mentioned for treating VRE and that is also in blood. Linezolid is not the drug of choice. Linezolid is a static drug. It takes 3 to 4 days for getting some effect. So linezolid is not a very good drug not a drug of choice for bloodstream infection. So linezolid then out of question. So what are the antibiotic option of VRE bacteremia? Daptomycin alone, daptomycin with ceftaroline, linezolid, linezolid with daptomycin or daptomycin with double dose tigecycline. So in last 1 year, I have used this combination in a patient with infective endocarditis. This problem is very high cost. For this combination, unfortunately, that patient didn't survive. And for 4 patients, I have used this combination. 3 out of the 4 patients recovered. But problem is GI side effect. पेशेंट को इतना गंदा डायरिया होता है, अगले 5-6 महीने तक बार बार वापस आएगा कि डॉक्टर साहब जा नहीं रहे, डायरिया हो रहा है, एक ही कंप्लेन और जिसका कोई ट्रीटमेंट नहीं है. सो डैप्टोमाइसिन विद डबल डोज टिगीसाइक्लिन इज अ गुड ऑप्शन. प्रॉब्लम इज ओनली डायरिया. एंड डैप्टोमाइसिन सेप्टारोलिन इज अ वेरी गुड कॉम्बिनेशन. You will get many articles mentioning this. Why ceftaroline with daptomycin? Why not daptomycin alone? Issue is daptomycin alone is it goes via lung for circulating. In surfactant, that pulmonary surfactant lyses daptomycin, so उसका effect कम कर देता है. तो for reducing the MIC, for boosting effect of daptomycin, we need daptomycin along with ceftaroline. I have just for a overview ये एक चार्ट बनाया है जहाँ पे all the anti-MRSA drugs, vancomycin treatment of choice for bacteremia, bone joint infection. This slide is not having any role for my presentation, just for understanding gram-positive drugs. Prolonged IV therapy is problematic for vancomycin. Teicoplanin, all is good. Only issue is little bit cost. Linezolid, specifically not a choice for bacteremia. Daptomycin is a very good drug. Dapto and Teico is a very good drug. Only issue daptomycin is very high cost. Again, clindamycin. Routinely I see patient is in shock. Very routinely I encounter this scenario. Clindamycin शुरू हो जाता है. Patient को जब shock है, patient को जब मेरो with clindamycin is not treatment of choice. अगर one issue is if the source of infection is something like necrotizing fasciitis or crush injury, ऐसा कुछ हुआ, primary या पोस्ट एब्डोमिनल कुछ सर्जरी हुआ जहाँ पे MRSA सॉफ्ट टिश्यू इन्फेक्शन सस्पेक्टेड है, जहाँ पे आपको MRSA के लिए PVL टॉक्सिन इनिबिटर कुछ यूज़ करना है, कुछ टॉक्सिन इनिबिटर आइदर ऑफ क्लिंडामाइसिन और लिनेजोलिड, तो क्लिंडा के साथ टीको यूज़ करना है, नॉट क्लिंडामाइसिन अलोन. बिकॉज पेशेंट को शॉक है, मतलब ब्लड स्ट्रीम मोस्ट लाइकली इन्फेक्टेड है, तो क्लिंडामाइसिन इज नॉट अ चॉइस फॉर बैक्टीरिया. Septran, again for bacteremia and prolonged IV therapy is problematic. Many side effects are there. Tigecycline, bone and joint infection is okay, but not a choice for bacteremia. Teicoplanin could be a good alternative for vancomycin. Problem is 12 mg per kg is a very high dose. Teico always needs higher dose of any drug. Like for daptomycin, standard MRSA dose is 6 mg per kg. But if it is enterococcus, we have to give 10 mg per kg. So VRE treatment for endocarditis or bloodstream infection, if it is ampicillin sensitive, anytime simple amoxicillin is better than teicoplanin, linezolid, daptomycin, any of the high-fi drug. Simple amoxicillin. Ampicillin with gentamicin or ceftriaxone, it is It is very elaborated topic because if it is Enterococcus faecalis, then treatment of choice is ampicillin with ceftriaxone. If it is other than something faecalis, ampicillin with gentamicin. So higher dose daptomycin, 10 to 12 milligram per kg per day, always in combination with something. Linezolid versus daptomycin for VRE, still jury is out. मतलब IDA से अभी तक कुछ recommendation दे नहीं पाया है. Patient treated with finally daptomycin with ceftaroline, clinically responded. So take home message, VRE combination therapy, if it is sidal, is indicated. Gram positive pathogen are less commonly encountered in hospital setting as compared to gram negative pathogen. Many drug options are there, but very meticulously, wisely we have to choose the option. Drugs cannot be used interchangeably and each drug has its own place. VRE combination therapy is indicated if the patient is on dialysis, mechanical valve or any metallic implant in situ, or the patient is having infective endocarditis, then definitely VRE needs sidal therapy. Thank you.
Very nice presentation, Dr. Saurabh. And you have elaborated certain things which we surgeons usually don't tend to look into. Especially the gram stain part of it was very good. And you routinely you don't do clindamycin, or you do only when it is in the panel for that particular.
Vitec panel is having clindamycin, so routinely
Clindamycin.
I report.
Okay,
But
yes.
Bansal Hospital is a very closed loop. We can
Yeah.
every time talk with the surgeon or anyone. So
Yes, sir.
over phone we advise like that.
Right, thank you so much.
Nice, Saurabh. It's good to see you are using Septron for culture because it's almost obsolete drug, almost obsolete. My one question is, you routinely use tricycline or ticoplanin. If you find a resistant bug for these antibiotics, what next?
Tigecycline for intra-abdominal infection definitely we use, and if the patient is in sepsis, then definitely use ticoplanin. If I am suspecting anything gram positive, then that option is not tigecycline. We have to use ticoplanin.
If the bug is resistant to these both,
Depends. If it is staph aureus, then treatment of choice is anytime daptomycin. For both staphylococcus.
see, you are working in Bansal, where patient can afford tigecycline and ticoplanin and daptomycin, but others, patients are not so affordable. So we have to use a judicious antibiotics for a judicious period of time, because in one slide you have mentioned ceftriaxone BD. Ceftriaxone should never be given BD. It's a TDS doses.
2 gram BD I have mentioned for typhoid. Typhoid it is written Mandel. 2 gram BD is a standard dose. One thing is, sir, we can use minocycline if the infection is in soft tissue, because soft tissue, even if it is resistant, in soft tissue the minocycline gets concentrated 4 times of MIC. So, agar resistant bhi hai, that might work.
See, my choice for soft tissue infection is azithromycin.
I think
I have no
really
experience.
you covered everything very nicely. But one very important point you mentioned, that is wait for interval point. Yeah, interval period is very important for inoculation. That is more important and very basic approach to conclude your treat that time. Thank you. I think you covered very well. Thank you.
Dr. D.U. Pathak, please.
लडा सर आपका स्वागत है. It was amazing, Saurabh. It seems like we should go back to college again. निगम सर से बात हो रही थी. So much changes have come. Like he said, the cotrimoxazole still exists. I am happy. And I have experience of a patient who took for 6 years for her UTI without any resistance. It is such a wonder drug. And what I realized today and enjoyed today, that golden hour for pathology is also there.
Yes.
As you said, golden hour for pathology is also, and the patients for incubation. That I learnt. A few childish questions. You have not mentioned metronidazole anywhere. Is it an antibiotic or what? It
one,
is a
sir?
childish patient.
Which one?
Metronidazole is not
Role of
mentioned anywhere.
metronidazole in GI infection.
What is the role of metronidazole?
Metronidazole for two purpose we use. One is for anaerobes, another one is for entamoeba. So all these meropenem, pip-taz, everything covers anaerobes. So additional, when we are using meropenem, metrozil should be avoided, and that is the thing we are fighting with our surgeon in Bansal. कि अगर मेरो दे रहे हो तो मेट्रो ना दो.
Amoxicillin आपने 4 बार बोला, मैं 3 बार सुना था अभी तक.
Amoxicillin. Doses of amoxicillin.
हाँ क्या 4 ग्राम.
नहीं, we have been giving. Let us 3 बार देते हैं शायद.
Mike.
And I'm so surprised that you reckon that metronidazole should not be given if you are using carbapenems. A surgeon cannot live without metronidazole, let me tell you that. There is a gross, phenomenal difference between surgical practice and you are a
Microbiologist.
microbiologist, yeah. So there is a phenomenal difference. I think, how many surgeons here can do without metronidazole?
No, I think.
So we still use metronidazole every day, maybe 3 times a day. I think you are talking of established life-threatening infection. That is a different scenario perhaps, because they would have taken metronidazole before they came to you. So that's a different scenario. But I would like to perhaps show my difference from your statement is that metronidazole still is used, both metronidazole and tenidazole are still used with good outcome results.
Then about fungal infections, as I know, it is opportunistic, and it is good that you have to look for it. So does it come from hospital, from his own body, and if at all, how long will you treat for fungal infections?
If it is isolated from blood culture, after documented clearance, means after first negative blood culture, 14 days.
Okay. And last, any role of local washes like hydrogen peroxide, metronidazole, pyridonardine, that local...
I don't have much experience.
Sir,
about
आपका क्या कहना sir? Local, does it have any role?
Sir, earlier we used to give lavage with metronidazole, but now since many years we have left that thing. Just simply washing with the normal saline is sufficient for that.
No,
What your
let
experience?
me just ask,
Yes.
are you talking of abdominal infection or perineal infection?
No,
Both
sir,
are
abdominal
separate.
infection. He's talking about the abdominal infection.
No, I
regarding
am
the
perineal abscess की बात
Okay,
कर रही हूँ.
okay, sir.
No, no,
Okay.
this is
Abdomen में
because-
भी-
yeah, I thought you were. Abdominal, of course, lavage is most important because you have to, I feel, and I'm sure all of you would agree, is that source control is of paramount importance. You have to control the source rather than dump the patient into a bath full of antibiotics. You need to control the source. And controlling the source is, of course, your diagnosis, your targeted surgical treatment, and washing out and drainage. These are perhaps most important things. As far as perineal wound is concerned, I thought you were talking about
Yes,
perineal
yes,
wound.
yes, sir.
I think, and perhaps you did not think it was perineal wound. We are great proponents of washing perineal wounds with one of these 3 or 4. I use Usol. All my cases I use Usol, but betadine or hydrogen peroxide is very good in lifting the debris. So we use them. Do they have an antibiotic property? No, they don't. But they cleanse it properly. So I think they are important.
Last but not the least, शायद intra-abdominal भी avoid betadine या povidone.
Sir, they have mentioned it. It is only for local application, not for the intra-abdominal infection. Yes, sir.
One thing, sir, when about this metrozil, sir, I was posted in Hinduja for 1 year for clinical ID. It's all about confidence building, sir. When we are using meropenem, metrozil हटा के भी क्या हो सकता है? Probably no one have tried. अगर try करेंगे, then we can see the difference. So I have posted in Hinduja, in Dinanath Mangeshkar, Jupiter. मोस्टली मेरोपेनम के साथ मेट्रोजिल अब अवॉइड करना इन प्रैक्टिस शुरू हो गया है. सो इट्स ऑल अबाउट कॉन्फिडेंस बिल्डिंग के रातों रात कोई डिफरेंस तो डेमोन्स्ट्रेट नहीं हो सकता है.
I think in this era of antibiotic stewardship, the role of infectious disease specialists is very high and it is very important. As Dr. Ladda said, source control is the primary thing for any intra-abdominal infections. But as surgeons, we have to accept that we are in changing times, and infectious disease specialists or patients who have qualified in that particular area, their opinion in intra-abdominal infection is very important, so that the antibiotics don't lose their relevance if we are using it for unindicated purposes.
I want to comment. I have seen metrogyl resistance. In AIMS, I have done a study and I have seen metrogyl being resistant, which we surgeons think metrogyl is never resistant. So we have to think about it. Upper GI we can skip metrogyl and we can use the meropenem, but lower GI where the anaerobe load is more, there still, as a surgeon, I will prefer metrogyl.
Last time we also, in AIMS I have discussed with ma'am, that time we also not concluded anything, but it takes time because metrogyl resistance है या नहीं है किसी को पता नहीं है, क्योंकि anaerobic culture कोई कराता नहीं है. आपके पास resource है मैम, private में कोई anaerobic culture नहीं कराएगा. So once we are starting doing anaerobic culture also, metrogyl resistance है या नहीं है, we can talk about that. Thank you.
Okay, thank you, Dr. Saurabh. Now I will request Dr. Ashok Ladda, please come forward and present a memento in form of book written by Dr. S.K. Nigam to all our chairpersons. Dr. Ashok Ladda, please. Thank you, Dr. Saurabh. Thank you, Dr. Ladda, and thank you all the chairperson. Now it's time to move for another presentation by Dr. K.K. Thakur. Dr. K.K. Thakur is a senior most intensivist in one of the corporate hospital of Bhopal, and he is going to take the presentation on very important topic for all of us as a colorectal surgeon, that is antibiotic prophylaxis in anorectal surgery. Dr. K.K. Thakur, please. And for this, for his presentation, I will like to invite the chairperson, Dr. Yogiraj Sharma, one of the senior surgeons of Bhopal Surgical Society, Dr. Suren Saxena. He is one of the founder member of Association of Colorectal Surgeons of India. Dr. Swagata Brahmachari, Professor, Department of Surgery, All India Institute of Medical Sciences. Dr. Nitin Garg, Head of the Department, People's Medical College. Please come forward to take this. Yeah, thank you, Dr. Swagata. Dr. K.K. Thakur, and over to all the chairperson for further proceedings.
Thank you, sir. Good morning, everyone. Although my topic is very basic, making presentation about this antibiotic prophylaxis, mostly I have tried to bring all possible latest evidences in this topic of surgical prophylaxis that we use for anorectal surgeries. But unfortunately speaking, from 2014, I have not seen any evidence, any latest evidence. What I have used for this presentation is the largest meta-analysis which was conducted by Nelson in 2014, who have tried to answer these questions in a very basic set. We are all using antibiotic prophylaxis for all our patients. Nothing new is coming in this area, but yes, whatever I have seen from that meta-analysis, I have tried to summarize it in a very short and comprehensive form. Seeing all my seniors here, I am a bit anxious, so please forgive me if I have missed something here. theme of presentation is very simple. We are going to do is the rational discussion about all possible aspects regarding antibiotic prophylaxis in anorectal surgeries with latest evidence, which are already 10 years old. Since we are in 2014, latest what has been done in 2014. Nothing much bigger has been done in this area after 2014. That meta-analysis comprehensively tried to summarize the findings in these area, whether antimicrobial prophylaxis reduces the risk of infection, target spectrum of bacteria, aerobic, anaerobic or both, best timing and duration of antibiotic administration, most effective route of antibiotic administration, IV, oral or both, whether any antibiotic is clearly more effective than currently recommended gold standard. And then lastly, I have added one survey which was conducted in 2017 for surgeons, Indian Society of Surgeon chapters. I have just added the summaries of that survey. And also we have done one Google form based survey for all the participants. The link has been shared to you, all of you, and I have got response, almost 20-25 responses I have received. So I will just try to summarize those responses here in this presentation. First and foremost question, whether antimicrobial prophylaxis reduces the risk of surgical wound infection. I think all of us agree that this question is obsolete now. But in past it was relevant, especially after advent of antimicrobial and new surgical technology. We can find those studies which have compared surgical prophylaxis with placebo. But it was done in 80s and later half of the 20th century when antimicrobial was advent. Today, interestingly, what I have found was now we are trying to get some 360-degree turn in this field also, where some surgeons and some microbiologists are now reconsidering this concept, where they are saying that we can actually use skin microbiome for wound healing, for surgical wound healing. So actually getting rid of them, completely getting rid of them is either beneficial or not. At that time it was settled that yes, we have to use antibiotic prophylaxis, but now in this now the 21st century literature is trying to review that question once again. So whether we should reconsider this concept, let the microbiome stay there in the natural flora, that can even help in wound healing. But this is something which is open for debate. This is one topic where our new residents, our new students can still use this concept for thesis or for research, that they can consider this concept once again to revisit the concept. That's it. Yes, what is settled is colorectal resections have higher risk of surgical site infection for obvious reasons. Second question that they tried to answer was the target spectrum of bacteria, aerobic, anaerobic or both. In this meta-analysis, what they have done was they have chosen a set of studies which have targeted, like in this series, the most common let me just summarize the microorganism that we target. Most common surgical site infections includes almost gram-negative, gram-positive and anaerobic organism. We all are aware of these organisms that we are using. Vancomycin resistance, enterophisium, Dr. Saurabh has mentioned that the incidence of MRSA, VRE, it has been increasing. So these target organism can be there in our surgical prophylaxis also, but for a particular subset of patients only, not for all. So what they did in this meta-analysis in 2014, they tried to get answer of this very specific question, that patient who are receiving principally anaerobic bacteria versus those who are receiving coverage for both anaerobic and aerobic. The later one, the subset who have received both aerobic and aerobic has lesser chance of infection than anaerobic only. Same addition of anaerobic coverage to aerobic coverage has also reduced the surgical site of infection. So this question was settled that yes, both aerobic and anaerobic coverage should be considered while we are considering surgical prophylaxis for colorectal surgeries. Antimicrobial prophylaxis using antibiotic with aerobic coverage only versus anaerobic. In this also they have found that there is a superiority of aerobic over anaerobic. Now this is one set where they have compared one subset of population who have received aerobic antimicrobial prophylaxis and another subset who has received antimicrobial prophylaxis for anaerobic only. In this subset, they did not demonstrate superiority of one over other. So head-on comparison between aerobic and anaerobic does not give any evidence, but yes, combination of aerobic and anaerobic coverage is always better than either of them. So standard of care, what we mostly practice in our surgical, as we have already been in touch with surgeons, and what we are doing here is a single dose of second or third generation cephalosporin plus minus aminoglycoside along with metronidazole. This is what we are usually administering. Timing, we will come to that, but mostly 30 to 60 minutes prior to surgery or surgical incision. Oral non-absorbable antibiotics like neomycin, erythromycin or metronidazole may be used 24 to 12 hours before the surgery. That is one question that we will tackle in the next slides, the route of surgical prophylaxis that we are using. So best timing and duration of antibiotic, that analysis in 2014 did not give any clear conclusion. They compared 30 minutes, 60 minutes, 1 hour, even 2 hours. There was no added advantage of one timing over other. What we mostly practice and what we have found from feedback of the participant of this workshop also, that most of us are comfortable in the time frame of 30 minutes to 60 minutes before surgical incision. So, but yes, repeat dosing consideration, operatively, if surgery duration is increasing, like it is going beyond 2 hours, 4 hours, so in that case we have to consider the half-life of the antibiotic that we have used for surgical prophylaxis. So when to repeat, that is what we sometime we decide intraoperatively, and there are some post-operative factors also which we will discuss in further slides. Duration of antibiotic was also studied in this analysis. Prolonged duration, post-operative duration, post-operative coverage for 24 to 48 hours. There was no added, this and meta-analysis did not show any advantage of post-operative coverage. But yes, that doesn't mean that we can omit that post-operative coverage. It is required in particular subset of patients, which we will discuss in further slides. The post-operative, the longer duration of antibiotic coverage. Longer duration of antibiotic prophylaxis doesn't offer any advantage, but there are few conditions where longer duration of coverage is required, which we will discuss. The next question that this meta-analysis tried to get answer was, what is the preferred route of surgical antiprophylaxis in colorectal surgeries, whether it is IV, whether it is oral, or it is both, the combination. Antimicrobial prophylaxis administered both orally and IV versus IV alone, there was statistical significant difference, benefit in favor of combined. When in this meta-analysis tried to find the answer in subset of the patient who have received only IV prophylaxis compared to IV plus oral had a better chance of better results with lesser surgical site infection. Same when they compared oral only with IV plus oral, the combination was found to be better. So this question was also settled in this meta-analysis, that combination of both IV and oral is always superior to either alone. Now there is this concept of mechanical bowel preparation, which is a technique that involves administration of osmotic substance. We all surgeons and all of us, when we are posting a patient for extensive colorectal surgery, there is always a dictum of trying to prepare the bowel before the surgery. This combination became standard of care in colorectal surgery, but recently there is a meta-analysis which concluded that use of mechanical bowel preparation prior to colorectal surgery could be safely omitted. So now this is something which is open for discussion, which is open for choice-based discussion between surgeons also, and in our survey also, which we have concluded with you, the speakers, with the presentation, with the delegates of this surgery, we have got a mixed response. How few of them are in favor of mechanical bowel preparation, almost 40%, 30% this of our current attendees, almost 30 to 35% are not in favor of mechanical bowel preparation before colorectal surgery. In parts of Europe, there has always been emphasis on IV antibiotic with no mechanical bowel preparation. They say less is better. Mechanical bowel preparation is not providing them any benefit for control of surgical site infection. But yes, there is one other section of this world where they are in favor of mechanical bowel preparation, and they summarize more is better to reduce the rate of surgical site infection. There is one faction who is saying that mechanical bowel preparation should be done. Whether any antibiotic is clearly more effective than currently recommended gold standard, which is second to third generation cephalosporin along with aminoglycoside and metronidazole. Is there any preferred combination, anything which has done better than this combination? This meta-analysis has not found any evidence favoring any other higher antibiotic for reducing the site of surgical, the rate incidence of surgical site infection. But few practical considerations are important, like institute to institute basis. If your microbiologist, if your infection control team, antibiogram of your institute is reporting higher incidence of extended spectrum beta lactamases, then prophylaxis can be modified to piperacillin tazobactam or cephalosporin sulbactam combination depending on the susceptibility. In patients who are found to be allergic to beta lactams, where we cannot use first and third generation cephalosporin, where we can use another class of antibiotics like fluoroquinolones, vancomycin can be used in this particular subset of patients. Now, this was the survey which was published in 2017, where almost 100 to 125 participants, senior surgeons from all across the country has participated to answer particular sets of questions. Almost all of them, 95% cases, surgical antiprophylaxis was selected based upon the classification of wound. Obviously, the risk of SSI was higher in dirty wounds compared with contaminated and clean contaminated. 36% of them preferred cefazolin as the first line of surgical antibiotic prophylaxis, followed by cefuroxime and monosef, as you can see, and coamoxiclav. So, in our Indian context, when we are talking about 2017, this survey, second generation, the first generation cefazolin was preferred to be the antibiotic of choice for surgical antibiotic prophylaxis. For preoperative prophylaxis, almost 40% surgeons preferred giving one dose within 1 hour prior to the incision, while 30% preferred to give it 30 minutes preferred. So this is also settled, 30 minutes to 1 hour doesn't make any difference. Surgeons are comfortable in this time zone for giving surgical antibiotic prophylaxis. Intraoperatively, 40% of surgeons redose the antibiotic every 4 hours. As the surgery progresses, if the duration of surgery increases, so if every 4 hourly, almost 40% of surgeons try to redose the prophylaxis. And reasons were half-life consideration, wound size, procedure, case complexity, estimated blood loss. If it is more than 1 liter, 1.5 liter, they tend to repeat the antibiotic prophylaxis, and literature preference. Few cases continued surgical antibiotic prophylaxis post-operatively also. This is Indian context, the survey and when they were asked when they consider post-operative dosing, it was in 23% when the surgeon and the team found that OT doesn't meet the required standards. Consultant surgeon preference was 22%. Lack of OT discipline in 20% cases, unreliable sterility of instrument. In these particular set of situation, surgeons tend to redose post-operatively also. With this, I will like to conclude here, but the survey that we did for our participants, I will just like to summarize what were the findings that we found among our participants. We have received almost 20 to 25 responses of the questions that were asked. Incidence of surgical site infection was less than 5% in almost 70% of the participants' institutes. So this is something good, that you are obviously getting less surgical site infection. Timing, almost 64% of the participants of this workshop were comfortable with the timing of 30 minutes before incision. And rest of the 35% were of the window of 30 to 60 minutes. Beyond 60 minutes, none of them was preferring. They wanted the surgical, that prophylaxis should be given in hour or less than that. What was the preferred route of administration when this question was asked? IV was preferred in 75% cases, and 25% cases the participant were in favor of both. Oral only was not preferred in any by any of the delegate. So either it was either IV alone or both IV or oral. But yes, it was in favor. The participants were in favor of IV most of the time. IV. What was the preferred target of coverage? Almost 95% of the participants were in favor of covering both aerobic and anaerobic. As senior consultant has mentioned, the surgeon cannot live without metronidazole. For that reason, aerobic and anaerobic coverage was then done in 95% of the cases. How often they were practicing post-operative dosing? To our surprise, 80% of the participants are in favor of post-operative dosing in surgical site infection prophylaxis. So this is something which is open for discussion. Why are they in favor of post-operative? Was there any reason mentioned like this, OT discipline, prolonged surgery, or whether it is just that antibiotic can treat anything, so it's just like that we will use post-operative also, because surgical site infections are more common in colorectal surgery. What was the preferred choice? So there was multiple combination. Was yes, metronidazole was found in all of the responses. So metronidazole plus monosef. Some of them were in favor of coamoxiclov, amikacin. So gold standard was that yes, all these three antibiotics can be used in various combinations. When do you consider antibiotic regimen, alternative regimen? As we have discussed that. Apart from these gold standard, was the reason of using alternative regimen when patient was sensitive to drug one response at night only. Piperacillin, tazobactam, clindamycin was used when they have found one patient to be sensitive, to be allergic to cephalosporins, beta-lactams. When they have found that patient is already have a dirty wound, there are sign of infection, fever before surgery, prior to surgery, patient has sign of sepsis. In those conditions, they have chosen alternative regimen. So this was the summary of the survey that we conducted among participants of this particular workshop. So with this, I will open the session for questions. Penny, please.
Good summarization. Only one thing I want to say, nowadays antimicrobial prophylaxis is to be continued till 24 hours only. You can redose within 2 hours if the surgery is more. It is as per ICMR guidelines.
Yes,
and WHO also says the same thing. So at the surgery is extending up to more than 4 hours, you can again redose as per the half-life. And you can give a second, or if the half-life is more, within 24 hours. After 24 hours, it is not known as antimicrobial prophylaxis.
Yes,
it is then antimicrobial treatment. So it depends on clean and clean contaminated cases. We only give antimicrobial prophylaxis. If there is a contaminated, definitely antimicrobial treatment is necessary. Okay. This was only my comment. Rest.
Sir. One thing I opened a question for the house, and like I think topic was anorectal surgery. So is there some difference in prophylaxis for anorectal versus colorectal? Colorectal is transabdominal mainly. Anorectal we go from below transanal. So I want to have opinion of the expert house. Like, is there any difference? And now increasingly use of laparoscopic route in colorectal surgeries. I think mostly it is malignancy. So is there any difference in the trend? Because tissue planes are less dissected. So I think we can have a discussion, maybe 5 or 10 minutes, if Dr. Sharda permits.
Yes.
Thank you for raising my question. Let us, Begum sir might agree that now it is time to separate colon from anorectal surgery. सारी चीज़ें बदल जाती हैं रेक्टम के ऊपर और नीचे. Everything changes. So now we should talk separately about colonic surgery and anorectal surgery. That's what I feel. And about the infective part, I had asked this question 40 years ago to my professor, जिसका जवाब आज तक मुझे नहीं मिला कि why these wounds don't get infected. एनोरेक्टल सर्जरी में मुझे याद नहीं आ रहा मेरा पिछला केस कब इन्फेक्ट हुआ था. How, why is
Sir,
it so?
in next presentation, I am going to answer that question.
About mechanical bowel preparation, suppose there is some problem in a particular society or in a mohalla, and if you take the all persons away from that, that is the purpose of mechanical bowel preparation. When you wash it, you wash the harmful bacteria as well as beneficial bacteria also. And when they will get the chance to re-enter in that colony, you don't know गंदे लोग अंदर आएंगे कि अच्छे लोग अंदर आएंगे. गंदे ही ज़्यादा अंदर आएंगे.
One last point, sir. Since many years, I have not used any laxative. I don't prepare the bowel, and I don't give anything a night before or any enema before to surgery, and I am happy.
Thank you. There are quite a few pertinent observations which have been made. There are few things which we must define very clearly. Colorectal is a different ball game. Anorectal is a different speciality altogether as far as antibiotic prophylaxis is concerned. Two, in our kind of a setup, we are not really too bothered with SSTI. If you do, and I don't think many of you sitting in the crowd here do a lot of abdominal colorectal, because I think majority bulk is anorectal surgery. Those who do colorectal, yes, we use more antibiotics there. Anorectal is a different thing. And like you said, that 40 years and you yet to see an infected bottom after you have operated on them. Maybe it is your hands who are which kill every bacteria that comes in the way. But this is an observation by everybody. And I don't think we are too concerned about SSTI in anorectal surgery. So we have to differentiate. I think I was very intrigued to see an MD anesthesia talk on prophylactic antibiotic, which is good. I admire your courage to speak in front of us. But of course you had to settle with a big trial that you just presented. It is very nice to say that you use it for 24 hours. I'd like people to raise your hands and tell me that, do you really use it for 24 hours? I don't. Do you? I think I was in US only 2 days back. I saw one surgery for a mastectomy and an implant. And I asked the plastic surgeon, who coincidentally had an Indian name, Jajurikar. So I asked him, I said, what about antibiotics? 24 hours. Good. Patient was known to me. I saw the discharge prescription, oral cephalosporin for 7 days. So there is a lot for what is said and what is done. I don't think we here only use IV antibiotic prophylaxis, that's about all, for 24 hours. 1. 2, as far as skin infection is concerned, I think majority of us are good in taking care of it just with good dressings. It might increase the hospital stay by a day or 2, or patients can go home with the dressing. Do we really need to hit them very hard just to avoid that little skin infection? I don't think we do. Coming to anorectal surgery, that is the only area where I categorically do not use any IV antibiotic prophylaxis, because I don't give any IV fluid. So it's a compulsion that I can't use an injectable antibiotic. So I only use oral antibiotic prophylaxis. The night before, yes, in such cases I do prepare the rectum, but I prepare it by giving oral bisacodyl. I don't give them any enema. So bowel preparation is out. I think what Dr. Nigam was saying is again has to be divided between colorectal surgery and anorectal surgery. Anorectal surgery, I would entirely agree, does not require any bowel preparation. I think it is again one of those things a lot more said than done. You just give them 2 tablets of bisacodyl, no enema, take them for surgery. Why there is no difference is because of the simple fact that formed stool is a friend, liquid stool is a foe. If you have liquid stool and you are operating on the colon, then you are more chances of, if suppose there is a little puncture, then your whole wound is going to get infected. So try not to put liquid stool into the large intestine at the time of surgery. So that's why bowel preparation now is almost given up. If you want to, or if you are working on, say, a bad toxic megacolon in ulcerative colitis, now that's a very rare and a different thing. So all I suggest is that, yes, antibiotic should be given. There is no need to give any IV antibiotic when you talk of anorectal surgery. You need to give it IV only when you are contemplating a big abdominal colorectal surgery. And I would not just give it for 24 hours. Yes, I would give it for at least 3 days. Because all said and done, it's not for SSTI that I am worried. I am more worried about internal peri-anastomotic infection. And if my surgery I feel is less than adequate, then I would perhaps go on giving it for 7 days. It all depends on your kind of surgery.
Sir, point well taken. एक छोटा सा comment. The surgery done in institute is different. The surgery done in private practice is different. Surgery done by Dr. Ladha is different. Surgery done by Dr. D.U. Pathak is different. So there are so many variables. In institution, you can do anything. If you have established name in society, they appreciate. Ladha साहब ने 3 दिन बोला तो जरूरत नहीं आगे. But when my patient goes to periphery or in small places, वो जब घाव ठीक नहीं हो रहा, फिस्टुला का, अरे साहब वो घाव सूखनी तो दवाई दी नहीं इसमें. So there are so many factors, but एक चीज़ है 3 दिन एंटीबायोटिक देने में नुकसान तो कुछ नहीं है. Thank you.
I think, thank you, Dr. Thakur, for a very nice presentation, and thanks to all the participants. Thank you.
Thank you, Dr. K.K. Thakur, and thank you all the chairperson. I welcome Dr. Subodh Vashne. He is past president of Association of Colorectal Surgeons of India. I will request come forward, sir, and please present a memento to our chairperson as well as the speaker. I will request Dr. Chirag. He is not here. In fact, I am also thankful to Dr. Santosh. Santosh is our Vice President of Academy of Critical Care Medicine, Bhopal. And you must be knowing that this entire program we are live on YouTube. So at present we are also on air. And he has taken the responsibility to answer all the questions put up by our delegates, those who are watching our program on YouTube. So thank you, Subodh sir, and thank you all the chairperson as well as Dr. K.K. Thakur. Now the next presentation will be taken by me also, and that is the role of microbiota in anorectal wound healing. And for my presentation, I will like to invite Dr. Puneet Dikshit, Dr. Krishnanand, Head of the Department, Allen Medical College, Dr. Gaurav Kohli, Dr. Vikas Lal. Dr. Vikas is Associate Professor in Department of Surgery in All India Institute of Medical Sciences, as well as Dr. Deependra. Deependra is intensivist in Bhopal Fracture Hospital. Can I go ahead?
Dr. Rajiv Shada sir is a very known figure in Bhopal and is very active and is always eager to go for these clinical meetings and clinical teachings. So over to you, Dr. Rajiv sir, for your presentation.
Thank you, Dr. Krishna. And my talk is regarding the role of microbiota in colorectal wound healing, future scope. When I was preparing my presentation for today's conclave, I remembering my olden days when Dr. Subodh Vaishnav and my professor, they used to teach me regarding the role of MBBP, that is mechanical bowel preparation in colorectal surgery. That time we were taking care of all colorectal surgical patients. We were giving the mechanical bowel preparation, all antibiotics, IV fluids. We were giving the good nutritional support. In spite of that, we were not getting the sometimes good results. At that time, sometimes we are having a wound dehiscence, an osmotic leak, surgical site infection, and so many problems. I was not knowing what went wrong, but I think today with my presentation, I can give some notes regarding the role of microbiota in wound healing, particularly in colorectal surgery. So the wound healing is always the same for anorectal wound healing. It is the same, just like there will be bleeding, there will be inflammation, there will be migration of the microorganisms, and there will be a epithelialization, and after that there will be a remodeling. So we should try to understand what is microbiota and what is microbiome. Microbiota is basically a combination of bacteria, microorganism, combination of bacteria, fungi, and viruses, and they are always present in the gut, mucosa, mucosal surfaces of the organs as well as the skin, and they in the anorectal regions, the microbiota composition can vary depending on factors such as diet, hygiene, and diseases conditions. Now, regarding the microbiome is basically the genomic studies along with the ecosystem of this microbiota. So that is called microbiome. So in anorectal regions, we are having 50 to 60% of these microbiotas are firmicutes. Firmicutes are basically gram-positive bacteria having a thick cell wall. Then about 20 to 30% we are having bacteroids, and in about 5 to 10% they are acinobacteria. So these are the factors which influences the microbiota balance, that is diet, antibiotics, hygiene, and age. Now we should try to understand what is symbiosis. Symbiosis means basically good bacteria as well as the bad bacteria. They are living together, just like Mr. Salim and Mr. Javed, when they were working together and they were giving the good results in form of good movies. But in dysbiosis, this is an example of symbiosis, when all the microorganisms living happily and giving good results. And when dysbiosis occurs, when there will be a preponderance of bad bacteria over our friendly bacteria, so something happens. And that will definitely have impact on the wound healing. We'll have a delayed wound healing, there will be a infection, there will be a stricture formation, and sometimes patient may develop anal incontinence. If successful healings takes place, so definitely there will be advantage of that. It reduces the pain, accelerates the recovery, and enhances the bowel control. So for coming to the diagnostic technique for assessing the microbiota in colorectal wounds as well as in anorectal wounds, we know that these petri dish techniques and all these things in our olden days, but nowadays newer and newer techniques, they have arrived in our field. These are called as molecular techniques to detect microbiota. PCR, we are very well aware of these things. We are doing all PCR techniques for detection of microbacterium. Now there are metagenomics, cryptomics. These are the newer techniques. Then for visualization of the microbiota, we are having fluorescent technique. Right now, we as a GI surgeons, we are all using this fluorescence technique to particularly for hepatobiliary surgery as well as for colorectal surgeries to check the anastomosis also. So this is the same technique we are using to visualize the microbiota. Then this is called fish technique, that is in situ hybridizations. Then again another technique that is called confocal microscopy. This is the advanced microscope where they are using 3D technology, they are using slit door technology. These are all advanced technique to detect microbiota as well as to visualize the microbiota. So now what are the therapeutic strategies and what are the potential applications of use of these microbiotas? We are very well aware of these probiotics. Basically, probiotics are living microorganisms, and in the form of lactobacillus, we are all using these probiotics, and they are having good friendly bacteria. Then prebiotics. Prebiotics, basically, these are the undigested fibers, and they are present in all these carrots, shaljam, all this gajar, etc. And they are always very useful. Now again newer things that has been launched in last 4 to 5 years, that is FMT, fecal microbiota transplantations. And scientists as well as surgeons, they are using these FMT techniques particularly for irritable bowel syndromes, ischemic bowel disease, and as well as for this irritable bowel syndromes. What they are using is they are taking this fecal matter from a donor side, and they are using colonoscope as well as these syringes, especially designed syringes, to take out this fecal matter from a healthy donor. Then they take all the precautions, and after that they have to follow all the rules and regulation of transplant surgeries, and they are getting the good results. Now again the scientists, they have come up with this role of biomarkers for predicting wound healings through this microbiota. Now they have developed they are developing this targeted topical treatment in form of ointments, cream, to prevent contamination of wound in GI surgeries. Now they have developed these biofilms, especially to prevent wound infections. So definitely there are many advantages of use of this microbiota in surgical wound infection. They reduce the inflammatory response. Definitely there will be reduction in healthcare cost as well as in hospital stay. Decreased risk of infection. Minimized need for surgical intervention. So surgeons and researchers are exploring microbiota-based intervention to enhance surgical outcomes. Thank you very much. I have cut down my presentation because Dr. D.U. Pathak is having a very good presentation on this colorectal wound infection, and he's come up with a capsule. So I will request Dr. D.U. Pathak, just continue. I will request our chairperson, please continue with Dr. D.U. Pathak also.
Okay, thank you, sir. Thank you for this knowledgeable presentation, and I think we should continue with D.U. Pathak sir to have his presentation now. Till that time the presentation is ready, can we have a small discussion over the last topic? Sir, Rajiv
Dr. Subodh Vashne is heading the team of transplant in Bhopal. So his experience regarding the role of microbiota in wound healing.
अभी डिस्कस यही कर रहे थे कि एनोरेक्टल वुंड्स जो है कि इन्फेक्ट क्यों नहीं होते जबकि वो शिट में पड़े रहते हैं.
Yes, yes.
दैट इज द रीजन, क्योंकि वहाँ पे ये रहते हैं आपके, अपन जो बात कर रहे थे अभी, ये सब वहीं रहते हैं बैक्टीरिया, और यही माइक्रोबायोम के कारण नहीं होते वो इन्फेक्ट. अदरवाइज आप सोचो कितने आपके पाइल्स के वुंड ही इन्फेक्ट हुए होंगे, मेरे को तो एक भी याद नहीं अब मेरा.
Sir, Dr. Ladda, what is your role of use of MBP in colorectal surgery? How frequently you are using mechanical bowel preparation in all colorectal surgery?
Again, let us differentiate anorectal and colorectal.
Yes, sir.
Anorectal doesn't require any bowel preparation. As far as colorectal is concerned, bowel preparation is required in 2 cases in particular, if there's a bad, I do a lot of IBDs, ulcerative colitis. If there's a bad colon in ulcerative colitis, because out of my series of 280 odd cases, there are 3 or 4 who ended up in ICU before the surgery, because I think the translocation of bacteria primarily occur if there is breach in the integrity of the intestinal mucosa, and that is the basic disease pathology in inflammatory bowel disease. So operating on IBD is, again, as I say, is a different ball game, and they do require not only nutritional but also antibiotic coverage to get good results, because the surgery is prolonged as well. They take about 6 to 7 hours to do the surgery. So there you do require it. If we talk of anorectal, because that is the main theme of today's discussion, like Subodh said, we don't get infection in the we get perineal infection primarily may be a perianal abscess. But following a surgery for a clean case like hemorrhoids or fissure in ano, the rate of infection is pretty low. You don't get it. Yes, you do get on, suppose you do a hemorrhoidectomy. So on day 5 to day 7, you would find that there is slight edema of the edges of the wound if you are doing an excisional hemorrhoidectomy. So there is a little inflammation, which I feel is perhaps chemical as well as bacteria, which normally settles if you take good care of the area. You do not require, but lately I have figured out that perhaps there is a little more preponderance of gram-positive bacteria there, and lately I have started using linezolid with very good results in such such cases where patient complains vehemently काफी pain, and there is visible swelling of only of the edges of the wound. I give them linezolid and I am getting a good response. So I feel there is more of a gram-positive infection which causes this thing, which I think is the skin organism which invades the edges. This is my experience.
Thank you, sir.
Sir, as far as the post-operative hemorrhoidal wound infection and things like that, it's said that dilution is the best solution for any pollution. So that's what we do when we are operating. We always advise our patients to have sitz bath. So that dilutes that area, that washes that area, and we apply topical ointment over there, which is antibacterial as well. So that's one reason. So dilution is the best solution for any pollution. Even for laparotomies, we'll wash. So if you see, even for laparotomies, even if you have got fecal peritonitis, the results are good. It's because of the dilution, we wash the lot of wound. For perianal infections, because we advise our patients to have sitz bath, that washes that area, decreases the bacterial load on that area. That is one of the reasons, apart from the antibiotics as well.
Greetings from Jabalpur. Thank you, Rajiv. I learnt a lot. और इस तरह की मीट अभी हुई नहीं कभी आज तक. The one nightmare which I had, an rectal abscess, became a life-threatening one after drainage, and such cases you have to face once in lifetime. I am not a superstitious person, but एक आश्चर्यजनक बात थी, टेबल टूट गया था जब उसको पेशेंट को लिया था, which I wonder. उसके बाद उसको जो है गायनिक उसमें लेबर रूम में ऑपरेट किया. जस्ट इमेजिन टेबल टूट सकता है क्या, बट इट हैपेंड सो. द कोर्स वाज यंग मैन 53 years एज, diabetic, with history of perianal swelling and fever since 4 days. Day 1 I drained it. Normally next day छुट्टी दे देते हैं, but next day he said मुझे पेन हो रहा है. He had also fever also. I examined. I thought I have left something behind. Again I drained it. It had a higher extension. Day 3 he became critical, and he thought of shifting to Mumbai. Day 5th, his laparotomy was done with retroperitoneal debridement. A long postmortem like incision. Later on I saw reflection of the colon, and debridement of practically whole of the retroperitoneum was done, plus a diverting colostomy. After postoperative 2 months, the colostomy was closed. Probably it should have been delayed because it was closed before the healing of the bottom. Fortunately, he healed in 6 weeks. Now the question to all is, could I have foreseen it? How to predict and how to manage? At the end, the discussion is open. And when Rajiv showed me the brochure, I thought this thing is missing in this meat, the necrotizing fasciitis. It is the flesh-eating disease. The perianal necrotizing fasciitis, you see such cases rarely. The time is the key to save life. Recognition, early recognition is must. There is a fast deterioration instead of improvement after IND. After IND, we expect that patient should do well and बहुत जल्दी अच्छा हो जाना चाहिए, but it deteriorates. And the earliest fearsome sign is the crepitus. These two interesting pictures I saw, which shows the levels and the bacteria where it is. Later on it becomes a sponge-like. Now the basic thing which we are dealing is, most of the times the infection goes from outside in, so it will carry all the bacteria related to skin and all. But here we are dealing where the infection goes from inside out. So the bacteria and all the organisms will be quite different. The reason is diabetes. Alcohol, I could not find the reason, but it is written. And all immunocompromised conditions like cancer, kidney or liver disease. They are caused by so beautiful organisms, Strepto, Staphylo, E. coli, Klebsiella. They look so stunning, but they are so dangerous. The management has to be at war foot. The extensive debridement has to be done. You may take many sittings, but don't stop. Keep on debriding, because as it is eating the flesh, you keep on removing the debris. Leave the rest to the critical care expert. जैसे डॉक्टर राय ने बोला कि now the time has come that we should move aside and hand over the patient to a critical expert. And do not hesitate for the diversion. Diversion always saves the life. जैसे ड्रेन के बारे में सोचता था कि to put in a drain or not to put in, put in. If you think to divert or not divert, divert it. And do not make the haste for early closure of the colostomy. And I wonder whether hyperbaric oxygen has any role or not. I really don't know. Thanks a lot. So small talk, but that provokes a lot of discussion. सर सवाल भी आप ही को पूछना, जवाब भी आप ही को देना है.
Somebody has to carry the can.
Because I have come here as a student.
Nice to see a student teach us. What I categorically missed in your, because I feel your case, capsule, and your later description were not matching. I think your first case was something different. What was the radiological finding in the first case, or you didn't do any radiology?
No, MRI was done.
What
it
did
was
that show?
it was ischiorectal abscess, that's all.
But ischiorectal abscess of what extent? Because
it didn't ऊपर नहीं extend किया था वो.
But you did not show that here.
No, I never had, I don't have any pictures or surgical
No, but
pictures.
at
or,
least there should be a mention, because
I should have mentioned.
yes,
I should have mentioned.
because necrotizing fasciitis is a different ball game.
Sir,
It doesn't extend retroperitoneally.
sir.
It is always there in the perineal skin.
So
And
what to call that, which
the-
extended above?
Yeah, yeah. But your case went in the retroperitoneum because
Sir.
laparotomy was done. So there I think the abscess must have been extending above. Which
Very
was,
fast.
Yeah, and also perhaps the drainage was not adequate. I think it is important to do a proper
It was
drainage.
very well drained, sir. Very well drained. And the repeat MRIs, they showed the extension of the this thing.
Of the disease, of the inflammation.
Yes.
Yeah, then perhaps the diabetes was the
culprit.
prime culprit. Because necrotizing fasciitis can occur without any anorectal disease. You must have, when you were...
Like Fournier's and all.
yeah,
yes,
Fournier's gangrene can occur without any anorectal
without
disease.
anorectal disease.
Even after a UTI, you can get Fournier's gangrene.
With a breach in the urethra.
That's right. And another thing is that I don't know how many you have dealt with. It never causes, in male particularly, because Fournier's gangrene is 10 times more common in men than women. It never causes devitalization of the testicles. Now, why does that occur?
It involves
2%.
fascia only and...
No, because it gets blood supply from the top. See, necrotizing fasciitis is a microvascular disease as well. And the one thing which is what one should suspect of it is that the symptoms are far more disproportionate than the finding. Patient is in a lot of discomfort and pain because his skin, perineal skin, is getting inflamed from first minute of this infection. And any diabetic, I am very wary of diabetic patient. The first thing that I ask in a perineal abscess is whether you are a diabetic or not. A few of them don't even know that they are diabetic. You get their blood sugar done, it's way high. Majority, they know that there is a diabetes and they do require immediate hospitalization. Don't just drain and let them go. They
So
would
this
have-
extension of the infection in the
In the
fascia,
sk-
can we call it a necrotizing or
Well,
not?
if the
To call
skin
it
is-
or not to
if
call
the
it?
skin is involved, was the skin involved in your patient?
Not much.
So then it is not.
And
You
what,
have-
what is it, sir?
It is just an infection, an abscess which perhaps carried on extending.
In the
And
loose
I'm
tissue.
Not, yes, I'm not trying to make any aspersions on your technique, but perhaps the initial drainage was not adequate. Perhaps.
No, sir, I don't have doubt, number one. Number two, after the repeat MRI, I again drained it fully. Then third day it ascended up, fourth day still up.
So
And
maybe-
those
maybe-
CT MRIs didn't show any.
Maybe
this
his
thing.
immune status, which,
Maybe,
quote under quote,
maybe.
was perhaps not right. Secondly, I categorically disagree with your assertion on fecal diversion. Even necrotizing fasciitis doesn't require fecal diversion. If there is a trauma, if there is a sizable trauma in the rectum, there is no need to divert them. Because fecal diversion doesn't change the course of the disease. The course of the disease is only changed by surgery. You should operate on them as soon as possible. Do more than what is required, because cutting the skin out is going to heal all right, but it would take care of his sepsis. Diversion is, I don't think, I mean, all the cases that I have dealt with, I never diverted them. Your first case, which you showed, required diversion because it has gone intraperitoneal. That's a different thing. But necrotizing fasciitis, which is limited to perineum,
No,
doesn't-
no, that doesn't need any diversion.
that's what I'm saying. It doesn't require diversion. Now, like you said, when you feel uncomfortable, divert. No, don't do
No,
that.
for such cases. Because
For first case, yes. But then there are not many colleagues like us who saw the first case.
since many
like you
years, sir,
did.
we have stopped diversion. There is no rule of
Yes, I
diversion.
don't think diversion should be done except if there is a total disruption of the sphincteric
Sphincters also.
mechanism, which
Sphincters
is
also.
difficult to contain.
Persistently leaking and all.
That is the
Yes.
only time that I would divert. Otherwise, even when I do sphincteroplasties, levatroplasty, I never divert the patient. These are my observations.
Thank you to you, sir. Thank you, Dr. Ladda, sir. And today, Dr. Sanjay Jain has also arrived. He is past president of Association Surgeons of India. I welcome Dr. Sanjay Jain as well as Dr. C.C. Chaubal, sir. Dr. C.C. Chaubal is one of the pioneers who started the gastroenterology concept in the central zone. I also welcome Dr. Arvind Rai. He was past dean of Gandhi Medical College. I welcome all these three distinguished senior person of Bhopal Surgical Society. Now I will request Dr. C.C. Chaubal, please come forward and present a bouquet to all our chairperson. Meanwhile, I will request Dr. S.K. Nigam. Dr. S.K. Nigam is one of the senior most anorectal surgeons in central zone of India who has done plenty of cases of anorectal surgery, and he is going to present his talk on interesting case capsule, infection after piles injection done by Quick. For this, I will request to chairperson Dr. Sanjay Jain, Dr. Rajesh Sood, Dr. Kushal Garwal and Dr. Tarun.
हेलो सर, मैं 1 मिनट लूँगा जस्ट.
Yes, डॉक्टर.
जी.
Yes, डॉक्टर दीपेंद्र.
तो सबसे पहले तो वेरी थैंकफुल टू डॉक्टर शारदा सर एंड डॉक्टर संतोष भास्कर सर फॉर सच ए नाइस कॉन्क्लेव दैट इज कोलोरेक्टल एंड एसोसिएशन विद द एकेडमी ऑफ क्रिटिकल केयर मेडिसिन. तो मैं आप लोगों के समक्ष एक कम से कम संक्षेप में एक एकेडमी ऑफ क्रिटिकल केयर मेडिसिन के बारे में मैं बताना चाहूँगा कि अभी कब लोगों को पता है कि जैसा कि हम ये इसकी एकेडमी ऑफ क्रिटिकल केयर मेडिसिन की स्थापना जो हुई थी, जिसके प्रेसिडेंट को डॉक्टर राजीव शारदा सर हैं. 2019 में ये हमने NGO इसको इस्टेब्लिश किया था और इसके वाइस प्रेसिडेंट डॉक्टर संतोष भास्कर सर हैं. मैं लगभग 5 वर्षों से शारदा सर और भास्कर सर से जुड़ा हुआ हूँ भोपाल फ्रैक्चर हॉस्पिटल में एज ए इंटेंसिविस्ट. तो मैंने देखा कि जो डेडिकेशन है, ये जो कॉन्फ्रेंस करने का मतलब था कि ये जो सर्जन्स के साथ मिलकर जो क्रिटिकल के जो एंटीबायोटिक पे हम बात कर सकें, तो इसके लिए हम जो न्यू स्टूडेंट्स हैं क्रिटिकल केयर में जो इंटरेस्ट रखते हैं, आइदर सर्जन्स हो, इंटेंसिविस्ट हो, एनेस्थीसियोलॉजिस्ट हो, तो इसके लिए हम डेली वीकली बेसिस पे एक CME करते हैं जो भोपाल फ्रैक्चर हॉस्पिटल के सेमिनार हॉल पे होती है. डॉक्टर संतोष भास्कर का ऐसा रहता है कि चाहे 2 लोग आएँ चाहे 3 लोग आएँ, ये CME हमेशा कभी रुकती नहीं है और ये हमेशा हर वीक में बुधवार या गुरुवार को कम से कम एक टॉपिक पे एक दिन हम लोग ये CME करते हैं किसी एक नए टॉपिक को लेके. तो मैं ये चाहूँगा कि आप सब लोग इससे जुड़ें और हर बुधवार या एक दिन पे कम से कम समय निकाल के हमारे इस CME में ज़रूर सम्मिलित होएं. इसके लिए आई एम वेरी रिक्वेस्ट टू ऑल ऑफ यू एंड दिस एकेडमी ऑफ क्रिटिकल केयर मेडिसिन. और दूसरा 2 मिनट में और आपका लूँगा कि ये जो आज का जो ये कॉन्क्लेव है, इसके पीछे मैं तो इवनिंग ड्यूटीज़ में वहाँ रहता हूँ फ्रैक्चर में. तो जब भी मैं आता हूँ 4-5 बजे, डॉक्टर संतोष भास्कर सर और शारदा सर, ये पहले से ही 6 घंटे 4 घंटे की इनकी मेहनत रहती है कि ये इस कॉन्क्लेव की कैसे तैयारी करना है, किन लोगों को बुलाना है. वाइस प्रेसिडेंट हमारे आज डॉक्टर अशोक सर हैं, बाहर से आए हुए हैं, तो सारी तैयारी कैसे अरेंज करना है. और ये प्रोग्राम जो है आज ये लाइव चल रहा है. तो मैं अपनी 2 पंक्तियाँ रखता हूँ कि नींव बनाते किसने देखा, देखा सबने मीनारों को, उजियारे तो सबने देखे, देखा किसने अंधियारों को. तो ये बड़ी मेहनत है इन दोनों के पीछे. तो दोनों डॉक्टर भास्कर के लिए, डॉक्टर शारदा के लिए तालियां. थैंक यू सो मच.
Thank you, Dr. Deepen, for nice words. Dr. S.K. Nigam, please.
Thank you, Rajiv. First of all, I pay my regard to Dr. Ladda sir. Me, Dr. Rajiv Sharda and U Pathak, all are 3 are the students of Dr. Ladda sir. Dr. Rajiv is a gentle and a goody-goody student of Ladda sir, while me and Dr. D.U. Patak are naughty students of Ladda sir. Second, often people ask me why you choose the anorectal surgery. Just for information, for last 17 years I am doing only anorectal surgery, nothing else. So I want to clear it that the person who brings me into the field of anorectal surgery is Dr. Subodh Vaishnav. If you blame anyone, blame Dr. Subodh Vaishnav. He brings me to the anorectal section and thereafter my anorectal page hoke reh gaya. Third thing about my book, I am thankful it is provided to you by Sun Pharma. It is Sun Pharma के सौजन्य से ये जो आपको बुक मिल रही है. Fourth thing, the 3 books has been shown by Dr. Rajiv Sharda previously. One is the surgical techniques by Dr. Kamal Gupta. One of my technique is also there in his book as a contributor. Second book he showed book by Dr. Kushal Mittal. Probably my chapter is also included in of anal stenosis in his book, and what I have included in that book all is included in my book which is in front of you. Fourth thing, with the permission of chair, I want to say ASI election is going on. Please vote. I am not telling you vote X or Y, but please vote. मैसेज ये जाना चाहिए कि आरिफ नगर में 100% वोटिंग होती है. ऐसे ही यही मैसेज जाना चाहिए कि एमपी में 100% वोटिंग होती है. इफ़ यू वांट एनी हेल्प, डॉक्टर संजय जैन इज हियर, डॉक्टर राय सर इज हियर, यू कैन टेक हेल्प ऑफ हिम हाउ टू वोट. बट प्लीज वोट टू whomsoever you want, you vote to him. Now I am taking only few cases. I will not take much time. My first case is a 30 years old male patient admitted with the complaint of pus discharge per rectum and pain. There was history of pice injection given by Ayurveda doctor. On examination, patient was drowsy, pulse was very feeble, BP was not recordable. There is a pus discharge from the anus. It was managed by in ICU by interventionist. How managed, probably Dr. Saurabh has already answered, and further Dr. Santosh will answer how it should be managed. But managed by interventionist in ICU. What I did only, since there is a profuse discharge and there was a history of pice injection, I did not intervene at that stage. I just lubricate a gauge with xylocaine jelly and soaked it in with betadine. With a well lubricated finger, I put the gauge inside the anal canal, and 1 week is outside. For 3 days it drained freely. There are a lot of pus discharge, and after 3 days, patient was in a position to send for CT scan, and this was the CT scan which shows there is a collection between the external sphincter in mucosa, in between. No further investigation is possible at that time, since the anal canal rectum is very friable. After some time, we send the patient for sigmoidoscopy, and sigmoidoscopy there is definite sleeve formation. Mucosa is completely separated from the deeper structures for quite a good length. So patient was managed conservatively. If I stitch the mucosa, there may be collection of the pus. So it is, since it is in a lower side, I let the drain it freely, and my patient recovers. Second case is also a case of 30 years old lady complaining of fecal discharge from the vagina. Again, there was a history of injection by the Ayurvedic, same doctors, 3 weeks back. And it is how it was there. Everything is I explained earlier. When I examine the patient, I can put my 2 fingers from the rectum, which comes inside the vagina, that there was so big gap. And there was, if you follow the artery forceps, there is a big gap between the rectum and vagina wall. And when this big gap, when I was put my suction machine and the artery forceps, literally I have to do the debridement in between 2 layers of the vagina and the rectum. So in the first stage, I did only the debridement, nothing is possible, thorough washing and thorough debridement. After 10 days, we again take the patient for surgery, and from rectal side, I completely repaired the rectal mucosa with interrupted sutures, inverting interrupted sutures by the vicryl. 20 vicryl is there, and this is the repair is going on. And then I repaired the perineal body with the interrupted sutures of vicryl. And I explained the patient that I am partially repairing it, since there is a collection, pus should be keep draining, and second surgery may required. This is again a complete repair of the perineal body. Fast forward करने का नहीं. Sorry, it is not showing the cursor for fast forwarding. Now the final is the repair of the vaginal mucosa. And if you see, the extent of tear in the vaginal mucosa is just posterior up to the cervix. I have to repair it from the cervix to downward. And then I kept the drain and I left it open. To our surprise, I kept the drain for 2 days, and to our surprise, it heals everything. No further surgery was required. My third case is also a case of same history of piles injection by the same doctor 2 weeks back. There was complaining of pain, anal area, fever. On examination, no localization of abscess. PR में there was a painful tenderness at 6 to 8 o'clock position, and MRI shows there is intersphincteric abscess. So I drained this intersphincterically. This is the just drainage. This is in my Alice, there is an internal sphincter. External sphincter I am pushing outside, and I am putting the fingers in it, and I completely drained the abscess, and the patient recovered. And just curate it and light packing. My fourth case is Dr. Anil Garg is here. It is Dr. Anil Garg's patient. I included a 45 years old patient admitted in the hospital with the history of IND or something else. What was done previously was not clearly known, but he was admitted with the Fournier's gangrene. On admission, there was total fecal incontinence and multiple wounds. It was managed by Dr. Garg on conservative line with the diversion ileostomy, since there was complete fecal incontinence. PR examination only, when I did the PR examination after some times, there was only few fibers of the sphincter contacting on my finger near the anal verge. There is no sphincter tone at all present above 0.5 centimeter of the anal verge. This was the after thorough drainage managed by Dr. Garg, and this is his proctoscopy finding. Mucosa is intact, but the sphincter is completely gone. So this is the external wound position. You can appreciate the depth of the wound by my curate. It is very deep. So we left the patient for some time to heal the wound, and thereafter we will plan for MRI to see the position of sphincter, and if required we do the sphincter repair or the graciloplasty. Thank you. If anybody wants my book, you can contact some former person with this number. His name is here. Thank you very much.
Thank you, Dr. Nigam, for this. I think there were 3 very interesting cases, and there are few things which I would like to highlight. See, in the scenario where we live, probably the quacks are doing more number of anorectal cases than the qualifieds. So this is something which all of us do face, but sometimes we also hesitate to put our foot into such cases. Dr. Nigam is there to rescue. I also remember one case where I was with him when he performed a laparotomy, and that was also a post-injection pile case, but that was a female patient, and she had again extension into the retroperitoneum. So these are the cases which do come and will continue to come. I do not know why the Indian public have more faith in Bengalis and Ayurvedas and what not. They will continue to come, and we need to face these kind of situations. And I think this presentation is going to be very helpful in managing such patients. So for the further comments, I will request my co-chairpersons and also the learned people from the audience. Sir.
Thank you, Dr. Nigam. It is very good presentation and cases are selected. I think you should be thankful to that Ayurvedic doctor who is sending cases to you.
Definitely, sir, I should.
Otherwise,
he is not sending. He is not sending.
Are creating problems for you.
He is creating the patient for me.
And you have managed the cases very well.
Another complication, which is they are usually injecting acid preparation in local isle. That creates the anal stenosis. That's why he make me perfect to do the different type of flaps in the as in anoplasty.
There is one Ayurvedic doctor who is deliberately, I know, posting some videos regarding us कि post hemorrhagectomy anal stenosis, जो आपने बताया सर मेरे को, तो वो खुद ब्लेम वो करता है ब्लेम कि जो हमारे आयुर्वेदिक इलाज से एनल स्टेनोसिस नहीं हो सकता, ये होता है सिर्फ हेमरेडिक्टॉमी या इवन MIPH या कोई भी सर्जरी हो एनोरेक्टल, then that will lead to anal stenosis करके. So we have to face them.
It was a long discussion. Some of our colleagues, some big anorectal surgeons suggest better you train them rather than criticizing them. You train them how to inject, and later on, when they will get the experience, they will do it properly. But if I tell myself, after 17 years of surgery, I have not injected so much sclerosant as he did. So he is more experienced in injecting than me.
Thank you again.
Thank you, sir.
It is a good things which we have seen. Thank
Dr.
you.
Nigam, Dr. Rai here.
Yes, sir.
I think I will make a comment of what Dr. Sanjay Jain has started as a very pertinent issue, that these practitioners of so-called alternative medicines, they have been right, left and center, they are advertising their things and without any check. So our association should somehow take cognizance of this and make certain things or guidelines probably, or some control over them. Number two is, in this era of integrated medicine, where the national policy is there with which now promotes other pathies along with allopathy. So integrated medicine is going to be a part. So what you told as a senior surgeon, anorectal surgeon, who says that these people have to be trained so that they do not create these complications, that too is becoming pertinent, especially in this unregulated, as we can call it, a market of alternative medicine. They need to be regulated. I think Dr. Ladda, sir, will be the most qualified person to put his comment.
Yeah, I'd like to say something on this issue because I very closely witnessed something which even changed my perspective about this. But before I say that, when Dr. Nigam said that he is one of those two naughty pupils of mine.
Students, sir.
Oh, students, okay. But isn't it paradoxical that he can write a book and 2 topics in the book, and I just could not write a word. But good job. Your book is good and your contribution is good. Coming to the topic which Dr. Sanjay Jain raised and Dr. Rai said, exactly a year back, I was invited by All India Institute of Ayurveda. I don't know how many of you know about this institute. This is at par, perhaps better than All India Institute of Medical Sciences. All India Institute of Ayurveda in Delhi is a central government undertaking, and they only give PhD in Ayurveda Shalya. I was invited to teach them as a tutor and show them my technique of septa for proper anorectal surgery that they could carry out. I was amazed to see the institute, a huge institute, and would you believe that Government of India has given them permission to carry out 42 surgeries? And would you believe that they do laparoscopic cholecystectomy? Yes, I was amazed to see that. They do MIPH, they are allowed to do MIPH. So now in present day, like Dr. Rai said, it is futile to say that association should do something to contain them. No, that's not possible, because the Government of India has permitted them to do it. And there they even have an ICU in All India Institute of Ayurveda. And huge funds that they have, very big, 17 acres of land that they are situated in. And they have a proper program. On any given day, an Ayurvedic practitioner would see at least 4 times more anorectal cases than any of us here. I was subsequently invited by a big Telangana organization of Ayurveda And some of the things that they do are phenomenal. They're good because they do have a big number of patients. And they are doing it very scientifically, Dr. Nigam. So I think time has come, as Dr. Rai said, sooner or later we'll have to not call them the quacks or the alternative medicine people. Yeah, they are qualified and recognized people. It would perhaps be worthwhile considering that they practice properly. I think the cases that you showed, we all see our share of such cases in our practice as well, and they are bad. It is just the way that they don't know where to put the injection or what kind of injection to put. You talked about sclerosant. One of Dr. Chiute's technique also involves putting a sclerosant for rectal prolapse, which I very categorically oppose to. But then you would perhaps know that in my training period, I was told that don't puncture the rectum. You believe in that? But then we have Dr. Chiute's technique. We are doing sacral rectopexy through the rectum, totally defying the fundamentals of surgical practice. But it works. So I think perhaps it is the time that we have to take them along for particular things. Don't teach them, don't make them your competitor. But for the sake of patients' population, it would perhaps be a good idea. Otherwise, I see government compelling you to train them as well. So it's not possible to, even for ASI, you cannot do anything about it because it is government recognized way that they do.
Sir, just I give an example. One of my colleague went to the quota to admit his son for the coaching of for IIT. When he talked about the course director, his reply was, यहाँ पे सर दौड़ने वाले घोड़ों को तेज दौड़ना सिखाया जाता है, गधों को घोड़ा नहीं बनाया जाता. Before injecting the sclerosant to the hemorrhoid, one should know how to diagnose the hemorrhoid. To my surprise, they injected the sclerosant in a pylorhoidal case. They injected the sclerosant in a carcinoma rectum. They injected in many times injected in a Fisher patient. Because they have don't time, they have to inject 200 patients in a day. That's my final comments.
Just one thing which I would like to say here, when I talk of the quacks, I never meant it to be towards the Ayurveda people, because see, that's an alternative medicine and that's a medicine of our own country, so we should not call them quacks. And if they are doing shalya or whatever they are doing, which they are allowed to do, but still I say, in this pile business, there are so many Bengali doctors who are not the Ayurveda qualified or MS Ayurveda, Shalya. So these are the people who are doing the majority.
I entirely agree, and my comment was not for the Ayurveda people. I think that those quackery must be stopped at any given time. I think it is the duty of the organization, and I believe IMA is doing a lot of work on that. The so-called chola chap doctors, because they are not even trained practitioners. So I think we must try to stop them. Entirely agree, but not Ayurveda, trained Ayurveda people, because they are also taught anatomy, physiology, embryology and everything. And they are taught by, medically qualified people. As I say, I was amazed to see that PhD program. How many institute of ours run a PhD program in surgery? But this institute is entirely for PhD. They don't do MS, just PhD.
सर मैं परमिशन लेने आया था सर की, उन्होंने यहाँ खड़ा कर दिया. आपके सवाल का जवाब ये है कि वो लोग इसलिए पनप रहे हैं क्योंकि हम लोग अप्रोचेबल नहीं हैं. हमारे प्रोटोकॉल्स, हमारी NABH, हमारे पैसे, हमारे अपॉइंटमेंट्स और हमारा बजट इज़ बियॉन्ड द रीच ऑफ आम पब्लिक, नंबर 1. नंबर 2, लेट अस नॉट गेट कन्फ्यूज बिटवीन क्वैक्स एंड दी आयुर्वेद पीपल. एंटायरली डिफरेंट है. मुझे भी BHU बुलाया था, जैसे सर को बुलाया. यू कैनॉट इमेजिन कि डिपार्टमेंट क्या है, राइट फ्रॉम एनोमेट्री टू एवरीथिंग और मनोरंजन साहू साहब जो पद्मश्री हैं, यू कैन नॉट इमेजिन. तो हम चीज़ों को मिक्सअप ना करें, क्वैक्स को हम आयुर्वेद वाला ना बोलें. थैंक यू.
Thank you, all the chairperson. I will request Dr. B.M. Loya, one of the very senior most surgeons of Bhopal Surgical Society, please come forward and present a moment to all our chairpersons, as well as Dr. S.K. Nigam. Meanwhile, I will request Dr. Anuradha Chaudhary. She is working in Department of Surgery, Gandhi Medical College, Bhopal, and she is the organizing secretary of MPSCon 2025. Dr. Anuradha, please.
My sincere regards to everyone, and hello to, or in other words, my sincere regards to all my seniors. Hello to friends and dear students. As all know, myself, Dr. Anuradha Chaudhary from Department of Surgery. I'm extremely happy to inform you that our next or upcoming 42nd annual conference, the conference MPSCon 2025, is being hosted by Department of Surgery and the Surgeons Alumni of the Gandhi Medical College, Bhopal. In the month of February, 8th and 9th February, venue will be Gandhi Medical College, and we had pre-conference workshop on the 7th of February. For this, some information, I would like to invite Dr. Rai sir. He is a HOD of our department, and he is a conference president of this conference. Please come and say a few words about our conference. Same time, I also say we have Dr. Sandeep Jain. He is our treasurer. Sandeep? Okay.
Very good afternoon, and as she has said, that 2025 will be a state conference will be hosted by us, and for that I wish to invite Dr. Sanjay Jain to come on the podium. Just our Department of Surgery, Dr. Sandeep Jain is there. We have learned head of the departments of LNMC, People's Medical College here, very senior faculty members from outside as Bhopal as well as from here. So we'll in this conference, which will to be held from 7th, 8th and 9th of February 2025, we will try to give you an academic feast as a traditional that we do, definitely, but we'll definitely have some twist to it and provide something new and something which will be stimulating for your mind and something good, maybe a platform for exchange of ideas over there. And I think apart from the speakers, there will be good contribution from the other senior members and junior members of the surgical fraternity. As a part of it is surgeons alumni. Many of the surgeons sitting here are alumni of Gandhi Medical College. Dr. Subodh is here, Dr. S.K. Nigam Sahab, Dr. Rathor, Dr. Sahai is there, he's there. So many people who are alumni of for MS from our college. We will require your contribution, and after 2014, so almost all 11 years, we'll be hosting this conference in Gandhi Medical College. So Dr. Sanjay Jain is the immediate past president of ASI. I would like him to say a few words.
Thank you, Dr. Rai. And what I would like to say, probably this was the time when there was, see, before it has always been a Bhopal asking for conference, and there was only one venue. Now it is good that we have so many people to host even inside Bhopal. Last time it was the team of Dr. Agarwal, Dr. Nigam, Rajiv, and these people, they organized a very nice conference. And this time the Bhopal. So till the conference you bid or you host, this is conference of some institution, venue may be some institution, but later on it becomes conference of the city. So it is an MPSC con, and we all, the Bhopal surgeons, are proud to host it, and I will ask each and everyone to contribute. And as the tradition, the Bhopal Surgeons Club have also invited our allied specialties. We have never hesitated in taking help from the seniors, from the other departments, and that's how we have enriched our knowledge, and this time will be no exceptions. Yes, definitely we will be hosting, and hope you all participate and enjoy this event. Thank you very much.
Thank you, Sanjay sir. Thank you, Dr. Anuradha. Thank you, Dr. Arvind Rai. So there are going to be so many conferences and workshops in upcoming months in Bhopal. Now this is the time to invite Dr. Subodh Varshney. Dr. Subodh Varshney is one of those persons who has started the concept of GI surgery in Bhopal way back in almost 1999, 2000, after returning from UK and after completion of his MRCS, and started the GI unit in BMHRC. So he is also past president of Acrsi, and he is going to tell us regarding his experience in infection in colorectal surgery. Dr. Subodh Varshney, please. And for his session, I would like to invite Dr. Arvind Rai, Dr. Bhuvneshwar Garg, Dr. C.C. Chaubal, as well as Dr. Sandesh Sharma is here. No, I think he is not here. Dr. Virendra Chaudhary. He is one of the GI physician who is exclusively doing GI. Yes, Dr. Subodh Varshney, please.
So before Dr. Subodh starts, a few words about him, though he doesn't need any recognition, but knowing him as an elderly brother or the senior in my medical college days. No, he's now elderly, na, sir. Ab elderly, pehle nahi the. So we have seen him as a versatile person growing in each and every field related to surgery, teaching the students, teaching us. I hope this talk as capsule is going to be fruitful for everyone. Dr. Subodh, sir.
Good afternoon, colleagues and friends. I am going to discuss two cases which we encounter time to time. The first case is in critically ill patients who are bedridden. This is a 60-year-old man came in emergency with distension of abdomen for few hours and not able to pass flatus. His vitals were normal, but abdomen was tympanic and very distended with high-pitched bowel sounds. He had been bedridden for a few days due to febrile illness, and his CT and X-ray, you can see it's a Ogilvie syndrome, which we will see in a lot of old patients who have fractured femur or who had been in ICU for some time. So this pseudo-obstruction of colon is without any anatomical or mechanical cause, and it is different from paralytic ileus as it is only affecting the colon, and the abdomen is typically tympanic and high-pitched. Now what do we normally do? We drip and suck, and you can add laxatives and prokinetics like erythromycin tablets, 250 milligram QID, but patient might not absorb it, but neostigmine does help, and it helps a lot. Now neostigmine, one warning, it has to be done under cardiac monitoring, so should be in ICU, and you start with 0.5 mg, and if it doesn't work, you can go up to 1 mg, and you can repeat it in a day and repeat it next day as well. Most of the patients would respond to this, most. But otherwise some intervention is required where we call our gastroenterologist colleagues. The first one you are seeing is a typical, this is a overtube, which is, this overtube, this is a commercial overtube. But what we have done is, this is a circuit, Bain circuit tube. So now what we do, we take a pediatric Bain circuit tube, put it over the colon, and then we do a colonoscopy and leave this tube, which is flexible, high up in the colon till where we are able to go. So when you do a colonoscopy, you deflate it once. But if you put it down there, it will keep deflated for a couple of days till it comes out. And this practical thing really helps. And I think it has never been, this is only used when neostigmine doesn't work, and this works always in such cases. So always suspect pseudocolonic obstruction in cases with chronic illness and bedridden patients. Try with prokinetic drugs and neostigmine before planning any invasive procedure. Flatus tube is mainly helpful only for sigmoid volvulus. It is not enough for the proximal colonic pathologies. This is a 37-year-old patient, similar to what Dr. Nigam had shown. This patient was all right 8 to 9 months back. When he started having bleeding PR, he went to a roadside quack, again had an injection, fever, sepsis. Admitted in patient found to have perianal sepsis with systemic sepsis. Patient was seen by a surgeon, and because the sepsis was, even there was guarding in the abdomen, so there was a colostomy, diversion was done. 6 weeks later, this diversion colostomy was closed, but no distal colon workup was done before that. So post-operative it leaked again, and then colostomy was put back, and then this patient went home. Now for the second time colostomy closure, he went to another hospital. Now here he again underwent a colostomy closure, and again without a distal colonic workup, and it leaked. So this time they did an exploratory laparotomy, and they could find that the rectum, upper rectum, and the lower sigmoid, there was a lot of inflammation and stricturing. So they resected it, did a anasmosis, colorectal, and they did a covering ileostomy. So patient is fine now. Now he has come for ileostomy closure. So we have done a distal lupogram, and there is one addition at the sigmoid colon. So, but we are able to pass colonoscope with slight angle, and we have evaluated him for tuberculosis and IBD, and now we will take him for ileostomy closure. So this is where they inject, and this is how these problems happen if they are not doing in the right plane. Here the injection go actually beyond the muscle. It goes into the muscle, and that's where all these sclerosant starts creating problems. So always do a distal bowel workup in the form of a scopy or a distal lupogram before closing the stomas. Always suspect and rule out chronic diseases like tuberculosis and IBDs in cases if there had been a leak of closure. Post-sclerotherapy in your clinic, look for signs of sepsis if a patient has dysuria or perianal pain. So you always tell patient after a sclerotherapy that if you have any problem, if the pain is there, a lot of pain, or if there is a swelling, or if there is dysuria, then you please come back again immediately, because these are the patients where you would like to pick up the sepsis or the inflammation early, put them on anti-inflammatories and antibiotics. And the right way to do a sclerotherapy is, if you see this needle, nowadays very few people would be using this needle. Now this needle, if you see, is angled and it has got a shoulder. So you can never push this needle more than 5 to 6 millimeters inside the mucosa. So when we do sclerotherapy, nowadays we all use Venflon needles. So we have to be sure that we do not insert more than 5 millimeter inside the mucosa. Thank you.
Very interesting cases. We have a gastroenterologist friend, so I'd like them to comment on the Ogilvie's first case.
See, we have, in fact, when I'd come back, I had an occasion to handle these cases. I still remember a case at Sharda Hospital. I remember a case at Asian Globus Hospital also, where I was summoned to handle these situations. Definitely, I would say see, whenever you have this assessment of a diameter of cecum is very important. Cecum going beyond 12 centimeters in diameter has a very high chance of ischemic damage and subsequently even perforation. Do not allow to to exceed that particular thing. So the patient has to be really watched carefully. Initially, can be managed for about initial 1 or 2 days by simple conservative measures like nil early and correction of all the electrolyte imbalance, especially taking in consideration calcium levels and magnesium levels also, which need to be properly corrected, other than potassium and all these things. Parental nutrition is required, and some of the patients do settle down after a few days with this, but definitely daily X-ray is required to watch for this particular dilatation. If the patient do not respond, ideally they should be shifted to ICU, and as has been mentioned, IV neostigmine. Normally we give out 1 milligram and given as an infusion over, I would say half an hour, something like that. And patient has to be monitored for any transient and sometimes severe bradyarrhythmia that this bradycardia that these patients have sometimes developed. They may even develop bronchoria, for which you give IV glycopyrrolate also in advance in these particular situations. Usually the response to neostigmine is quite dramatic. I have seen in both these situations, the moment you give within minutes, I think explosively they pass platters and stool. Sometimes so much so that a person standing several feet away from the feed was completely soiled by the spurt of stool going straight on him. So that could be really this thing. The response usually is seen within a few minutes, so sometimes even 30 minutes may be required. And as mentioned, if the patient do not respond, you may repeat an injection, but say after 1.5 to 3 hours later, not before that. You may repeat it after next day also if the person is partially responding. Regarding decompressions, yes, a careful colonoscopic decompression may be needed, but you should be very careful not to insufflate because the colon is already dilated, and the chances of inflating the colon and subsequently creating perforations are high. But if you do a careful colonoscopy, you should be really expert in doing colonoscopy because entire colon will, it's not like you giving a peg leg and you have an absolute beautiful colon over there. It's all full of. You do a careful colonoscopy, and not only that, there are certain very thin kinds of decompression tubes which can you pass through the colonoscope and allow to stay in the cecum over there and come out. Many patients would respond to that. As I have mentioned, all these measures actually help almost 90% of the patients. Most of the patients do not require surgery. Only it's a small fragment, about 5 to 10% who do not respond may have to go for surgery. But they usually respond well. And it's quite a common situation. If you take an X-ray, normally you will have cecal dilatation, ascending colon dilation, and there is many times a cutoff at splenic flexure level. So you have to rule out when distal obstruction in those such situations.
So through the colon tubes, are very
thin. I know there are chances of blockage are there. Definitely,
that's why over tubes are better.
What they mention is once you have put this thing, a gentle saline flushes are repeatedly required to keep that particular tube patent. That is what is mentioned in that situation if you are using those particular tubes because they are very thin. Unlike the large tube that you put for any distal kind of a distal. But remember this, in majority of the times, the descending colon, rectum, etc. are not dilated in Ogilvie syndrome. Main dilatation is seen in cecum, ascending colon, or up to the splenic flexure. Then you have a cutoff over there. So majority of times, if you need a decompression, the end has to be in the cecum. Take a small cylinder tube and keep flushing to keep it open.
So the only question is that how much we should wait if it doesn't respond to any neostigmine or decompression measures?
4 days, 5 days.
No, I think we will go clinically.
Yes,
If there is tenderness, undue tenderness in the right side of abdomen, you will go in early. If on radiology the cecum is reaching 10 centimeters, you would go in early. So I think
4 to 5 days are required. Beyond that, of course, the mortality
Yeah.
or weight mortality. Usually under observation, not beyond 5 to 6 days.
So for the surgeon, it is important when he comes across these distended abdomen to rule out Ogilvie's and not an organic obstruction. That would be one challenge. And as Dr. Chaubal has clearly pointed out, there will be a cutoff point at the distal half of the transverse colon. So that is one. The other part is that the dilatation of cecum should be monitored so that we don't let it dilate and we don't land up with a surgical problem in a case which can be managed conservatively. Regarding the other cases, I think Dr. Sharda is getting impatient. There's any questions from the audience, please?
I find it very intriguing, Subodh, that so-called surgical specialist went in to close a colostomy without looking distally. Now here we are talking about quacks. What would you call them?
We
This
need
is-
self-regulation
I
also.
mean, people are doing MRI for simple perianal abscess, and they don't assess the distal colon without before closing the colostomy. I think that is a crime. That is an absolute crime. So that is all that I can say about this case. It is interesting because it is interesting, but it is unpardonable. Here we are sending people for flexible sigmoidoscopy, even for small hemorrhoids. And there nobody thought of putting a scope inside. So I think that is all that I can say about this case. I hope you would agree. Two, they resected it.
Yeah.
What was the histology?
Not tuberculosis or granulation and inflammation. That's
No, but
it.
when you went in, when you are going in, you are not.
No,
closed
no,
the
I
ileostomy.
didn't resect. It
No,
was
no,
in
no,
the
no,
second.
no. Like now you are contemplating closing the ileostomy.
Yeah.
And you find that there was something still there.
No, there was just when we were doing colonoscopy, so at some point there was an angle, and there we had to really bend hard to go in. But the mucosa was normal, and when we did a lupogram, rather from
Yeah.
the down a barium,
Yeah.
it was quite okay.
So there was no mucosal disease.
No mucosal disease and not narrowing.
But
it's an addition. That's why it's not very pliable.
So I think the message should go to the surgeons, if they are from your city,
Yeah.
that this is not the right thing to do.
Very true.
Thank you, Dr. Subodh. Thank you, all the chairperson, Dr. Arvind, Dr. Bhuvneshwar, Dr. C.C. Chauban, Dr. Virendra. I will like to invite Dr. Swagata to please present a memento to all our chairpersons, as well as Dr. Subodh. Meanwhile, I will request Dr. Ashok Ladda, past president of Acrsi, to say something about this conclave, and immediately then I will request Dr. Santosh Bhaskar to prepare his presentation for panel discussion. Dr. Ladda, sir, please.
About 10 days back, I was contacted that Rajiv is doing this little program and I should be a part of it. I was in USA. So I said, can you, he called me and I didn't, of course, didn't pick it. So I sent him a message that I am in USA. What do you want from me? Your experience about treating these colorectal infections. I said, but I don't have the time. Firstly, I declined that I would not be able to come. But then I said, okay, I'll come, but I won't have the time. I only came about 2 days back. I won't have any time to make any presentation. So I'm glad that he has changed my topic. He has asked me to just talk something about the conclave. May I record it all in front of you that Rajiv is a great crusader. He would like to do good programs, and I admire his courage. I admire his resolve to do programs on colorectal surgery and do it in a proper manner. Gets the right people to come, and he pushes them very hard, like me, that okay, you have to come, you have to be there. So it's important too. This topic standalone is not discussed so very often. So this was a good thing that he got a mix of microbiologists, physicians, anesthetists, and surgeons, and everybody. So that is a good platform for discussion. All in all, I admire your courage, and I thank you for organizing it. And programs like this, since he has taken over as an executive of the Acrsi, all his maneuvers are very well appreciated by Acrsi, and we are always here to help him. He already has good friends like Nigam and DU and Subodh, Dr. Loya, and of course Dr. Chobal. I had a little brief encounter with somebody before coming here, and the only name that he took, he's an influential person of your city, was Dr. Chobal. You know Dr. Chobal? Yes, I said I know him well. So that was nice to hear, and I am so glad that I came here even for a few hours. So well done, Rajiv. Thank you.
Actually, Dr. Ashok Ladda is going to cover the anorectal infection part during our panel's discussion. Yes, yes, we'll adjust it. No problem. Do chair on. So for panel discussion, I will request Dr. Santosh Bhaskar. He is Vice President of Academy of Critical Care Medicine, Bhopal, very enthusiastic intensivist, and he is Chief Intensivist of one of the corporate hospital of Bhopal. And our panelists are Dr. Ashok Ladda, past President Acrsi, Dr. C.C. Chobal, Dr. Subodh Vashne, Dr. D.U. Pathak, Dr. Viren Chaudhary, and Dr. Atul Agarwal. Please come forward.
Good afternoon, everyone. This is somewhat different in a way. The panel, I started with a case scenario where I'll try to involve you as an audience, and then we'll have expert opinion on those questions which I have posed. So I want your participation as well. So should we go ahead? Okay. So we'll start with the case. Change in your PDF में भी तो चेंज होगा ना. Okay. So we'll start with the case. Is a history. 56-year-old male presenting with 5-day history of progressively worsening anal pain and fever. Previous history of diabetes and chronic constipation. He denied any history of recent trauma, surgery, or any rectal disease. Presentation is complaining of excruciating pain localized to the perianal area with swelling and erythema, and has difficulty passing stool for past 48 hours, developed chills, sweats, and confusion over the last 24 hours. His vital signs is fever with a blood pressure of 95/50, with a heart rate of 120, respiratory rate of 26 per minute, and oxygen saturation on room air of 92. So, with a physical examination, he has tender perianal swelling with some fluctuation, indicating an abscess. Skin around the abscess was erythematous with no purulent discharge noted externally, but mental status is mildly confused. So, usually when we tackle such cases in our clinical practice, the first question which does come to anyone is whether it is an infection or sepsis. So the question is, how can we differentiate anorectal infection from anorectal sepsis? Basis clinical picture. Do you have any idea? So we'll take help of our panel. My first question would be to Dr. Chobal to answer this.
See, whenever you have this particular scenario, I think I am audible. My
video.
also loud, you see. Whenever you have such a situation, If you look at a spectrum like that, in a situation where you have inflammation, you have a spectrum from SIRS, sepsis, severe sepsis, or septic shock. Let us look at the spectrum. SIRS, you have certain criteria that temperature beyond, say, 38 degree or less than 36, or count more than 11,000, less than 4,000, or blood pressure which is low, and all these things. There are 4 criteria, out of them 2 should be positive.
True.
If SIRS is associated with either documented or suspected infection, it is called sepsis. Severe sepsis means there is overt organ failure, and septic shock is refractory hypotension. True. That is there. In this particular situation, for example, if you look at this thing, whenever we encounter a patient, regarding the sickness of a patient, you have to make an immediate decision whether this patient is sick, needs to have an ICU admission. For that, usually we go for a kind of a scoring. I think the quick SOFA is the one thing that we use these days in our clinical practice. You have only 3 situations there. If there is a mental confusion, you have a BP which is less than 100 systolic, and a respiratory rate which is more than 22. This particular patient satisfies all of them. That means he definitely has features of severe sepsis and deserves an admission for proper monitoring in ICU.
Okay, sir. Thank you. So I hope the point is very clear. In our clinical practice, in our OPD practice, where we do not have any access to lab, we have patient history, clinical examination to support. How can we differentiate between sepsis and infection? We have a tool called Quick SOFA, if you have heard of. This is about Quick SOFA. There are 3 clinical conditions, and it is, if you have 2 present, then you can suspect it to be sepsis rather than infection. So that makes your job easier. With your clinical acumen, you can differentiate in OPD that where I am going to send this patient, what I am going to do, whether to wait for a long or to start with an antibiotic and drainage early. So these are the criteria. You have 3 criteria with altered mental status with a Glasgow coma score less than 15. He is mildly confused. So the GCS would be less than 15. Respiratory rate of 22 or more. And systolic blood pressure, usually wherever we do tackle systolic blood pressure, it is usually 90 systolic, enough for many of the guidelines. But for Quick SOFA, they have categorically stated it to be less than 100, not 90. So based on these criteria, clinical criteria, if you have 2 present, you strongly suspect sepsis. And in our case, it is all 3 present. So it means the tool dictates its term like be fast, be early, be aggressive. Sir, do you have any other, like if we have labs as well, what should we do for, like I'll talk of SOFA score. It is Quick SOFA to begin with. Now we have SOFA which is not quick. Why it is not quick is because we need to have labs in our, so labs will dictate its term, and there is a scoring system which I think you must be aware of rather than doing it, because if you are aware that there is something, you can really do it when your patient is admitted in ICU particularly. That time you can be more specific with your scores. And I'll not touch this in much because being a surgeon, I think clinical thing comes up most and then move on. So if I apply SOFA score, it is intermediate to high for this particular patient before even having the. So the next question is, when should we apply Quick SOFA or when should we apply SOFA? The answer, I made it clear that when you have a lab, then you particularly think of accumulating those lab in your SOFA score and coming to a number.
So the idea is, that's just a minute. The idea is Quick SOFA actually will guide you that patient goes to ICU.
Confirm it.
But subsequently for proper evaluation, for subsequent prognosis,
yes,
subsequently deciding to escalate or de-escalate antibiotics, etc., that a detailed SOFA score plays a role in that particular situation.
True, sir. So my next question would be to Dr. Pathak, sir. Such is the case, sir, where we have a case who is highly suspected of being in sepsis rather than being in infection. So question is, how quickly should we, like, whom to apply what?
Actually, as it was in my own case.
Yes, sir.
It was
Your
in
case.
my own case. This infection spreads very fast.
Yes.
Time is the key. And as Dr. Ladda suspected that I might not have drained the infection or abscess properly, to go to that point, now imaging is very important. And the perianal ultrasound
Yes.
is a quick investigation which tells almost 90% of what the MRI will tell you by losing your 6 hours further. So a quick perianal ultrasound and as fast
proceed.
as possible without bothering for his oral status.
Yes. So the case continues. We started on empiric broad spectrum antibiotic and transferred to ICU for monitoring, further monitoring and support. So in this patient who is having anorectal sepsis, how critical is timing of surgical intervention? So this question I would like to ask Dr. Ladda, sir.
Well, these patients only require surgery, if anything.
Yes.
So timing of surgery was yesterday. So what I'm trying to say is that as early as possible.
Yeah. Yes.
Because for like you said, being an intensivist, when should we convert a Q sofa to a sofa? I would like not to give you any time to convert it to sofa.
Yes.
So in my practice, when the patient walks in or when the patient is taken into my consultation, I know he is just an infection or sepsis.
Yes.
Come whatever may, my patient goes to a sonologist first before going for the blood test. I send them immediately to my sonologist, who
Then-
quickly tells me, sir, ye pareshani hai.
Right.
Then he goes for the lab, gets into the hospital, and is taken up for surgery then and there only. Sometimes I am still waiting for blood test to come, but you have to drain it. Because once you have the sonological findings, as I do all my cases under local anesthesia, I don't need to wait for the anesthetist to give me a green signal.
Right.
I take them to theatre and I
Train.
drain them properly. So that is the timing for my surgery.
As the belly says, the sun should not set on our abscess.
Right. So we are very clear that, sir. Yes, sir.
What is when we are talking of the sepsis?
Yes, sir.
And the severe sepsis, something which comes more important is because we have gone to the management, and the initial management bundle, which is recommended by the
Surviving sepsis.
Care, and
Yes.
the 1 hour and 3 hour bundle, they are very, very important.
Yes.
And something which is very important, which a clinician should never miss, is to get the microbiology of the source. So it is important to, if you, unfortunately we always get the handled cases. If you get a primary case, it is good to get the cultures, especially the blood cultures, and if the local cultures are available, they should be taken.
Yes.
Then the broad spectrum antibiotic, and here the something which is followed is the de-escalation of antibiotic rather than the escalation theory. This is important. And one word about the SOFA. SOFA also dictates you about the prognosis of the patient.
True.
And of course, as you say, the source control, definitely the data suggests that this source control is important. When you do the source control within 24 hours, as a bundle, the prognosis is really good and it improves the prognosis. These are the few points which just I wanted
Yes,
to
sir.
add to this
Yes, sir.
discussion. Thank you.
Just one
the
comment actually.
Points
Just-
are well taken, sir. Yes,
Just one comment, like when such patient comes and he has got a Q-SOFA score, actually sonography is an observer variation. It is not like a investigation which you can see. So if it might be only infection, it might not be a pus collection, it might not be an abscess. So just to take him for surgery directly
After sonography.
after sonography, sir.
Yeah, I can't do surgery without a sonography.
But
Sonography is done only to figure out if there is a collection. If there is only thickening of the tissue, I won't take them for surgery.
Because certain patients like may have a comorbid conditions, and along with that there might be only a perianal infection, not a collection. So in that cases, what to do? Because
What
it
do you
might
mean
not
by-
be a collection inside. It might be an infection, severe infection, and because he's having comorbid like diabetes and all, and the infection has got.
So once the collection is ruled out,
yeah, that's what I'm saying, sir.
then of course medical treatment is indicated.
Okay, sir.
Thank you.
But if there is a collection, don't wait. Even if there is the slightest of collection, don't wait, drain it. Because this is the only way to alleviate formation of a Fournier's gangrene or necrotizing fasciitis. If there is a collection, don't wait, just go in.
We have focus, this point of care ultrasound actually. The moment the patient is hospitalized, they get it there itself on bedside
Yes.
also.
So,
and take an action.
So even the panels.
There is one point. Whether you go for sonography or you don't go for sonography or you investigate, from medical legal point of view, it is necessary that you must investigate. Otherwise, if anything goes wrong, then you will be in the court. You will be sued, and you will be asked what investigations you did and how you investigated. What was the early symptom? From medical legal point of view, it is must.
Okay, sir.
I think what we do is usually what is mentioned in surviving sepsis campaign, that is
Yes.
sepsis 3 that is there
Yes.
now. This 1 hour bundle that he has already mentioned is the
Yes.
moment the patient, you encounter patient, you have these features like what you have mentioned in this patient. Immediately the crystalloids are started, 30 ml per kg, the blood cultures are drawn immediately and the shots of antibiotics are given within 1 hour.
Within 1 hour. Yes.
And if you have a POCUS over there, that is point of care ultrasound over there, as Dr. Ladda has said, you immediately do it, find out this thing and subsequently take an immediate action to remove the source.
Yes.
I just
Sir, your
wanted to
comment.
add. I just wanted to add that where the facility is not available and you are confused, do a wide-bore needle aspiration and try to see whether something comes out or not. That can always be done.
If you have a strong
Clinical
collection
suspension
and a
clinical
patient in sepsis.
suspension,
Yes.
and you don't have a facility of sonography,
Yes.
you must go ahead for the wide-bore
Yes.
aspiration.
So moving ahead, we have next question, which is about whether in all cases do we need surgery or we have something like where we can be conservative in our approach. So the question is to Dr. Vashne, sir. Please.
See, if you have got a small infection,
Yeah.
or you have a superficial one, or you have a very early one, and the patient is stable, Q SOFA is 0.
Yeah.
So in these cases, you can try, and on clinical examination, you are not seeing a huge area of cellulitis. It's a very small area of inflammation. In these patients, and PR is not, there's no bogginess, there is no severe pain. In these patients, you can try conservative management with broad spectrum antibiotics. But having said that, you have to examine these patients repeatedly every day to make sure that it is decreasing and not increasing. Otherwise, you would have to do an intervention if it is not decreasing. In comorbid patients where there is a lot of morbidity, if there is a sepsis, if there is a pus, even how many comorbidities they may have, they will require drainage somehow. The only thing what you can do is do it as Dr. Pathak has said, put a local anesthesia and put a wide bore tube, wide bore needle, and at least aspirate it, so that the sepsis part start getting controlled little bit if you are unable to operate on these. But as Dr. Ladda said, you can do in his septa anesthesia procedure, you can do all types of anal surgeries in that.
Okay, sir. Yes, sir.
My observation is, I have done many abscesses with intradermal anesthesia, it works. If you give intradermal local and plunge in a 11 number blade, if I have this thing, aspiration, wide bore needle aspiration, I find something, I can plunge in the 11 number blade with intradermal local
Usually
anesthesia.
it works because for
Intradermal. They say that it doesn't work, but it works.
For anorectal sepsis, at least it works.
No, any abscess,
Ah,
intradermal skin.
If you
this
have
thing,
deeper
it
abscess in
works.
abdominal or something,
That's a different
That's a
story.
different
That's a
story. So,
Dr. Ladda sir, do you recommend the septa in abscess case also?
Like I said, I do them all under septa. This, you may call it a hybrid technique, what DU said. It's difficult to even examine a big abscess. They are tender. What I do in such cases is just an intradermal local injection. Once the diagnosis, I don't do aspiration for sake of diagnosis, because I get sonography right, left and center. You know that I am a sonography enthusiast. So I put an intradermal injection and aspirate the pus. Once you aspirate the pus, whether it is 10 ml, whether it is 50 ml, the patient suddenly becomes quite comfortable. And then you give a septa, and then you can, because I like to do not only just drainage, I would like to locate where it is coming from, and I like to go up to the crypt and open it. That is the only way to reduce the rate of post-surgery, post-operative fistula formation. I always go to the root cause of abscess and deal with it as well. So that I do under septa block. Drainage is just with intradermal injection, you can take the pus out.
Okay.
Dr. Santosh, don't you think the pain part should also be taken in consideration while thinking for surgical intervention?
Surgical intervention, as mentioned, is a local procedure which usually is taken under care by local anesthesia as and when required. But for example, if your patient is in septic shock, like my patient who is presented in a sepsis state, have a blood pressure of low blood pressure, this patient might need resuscitation before taking for the procedure, like resuscitation in 1 hour and then moving to OT and doing all the things. So pain consideration for any abscess would be taken as a case by case basis, where you tend to look at the patient, tend to look at the physiology and the urgency. So compiling all together, the decision should be judgmental to the clinician and the patient. Patient may tell what needs to be done. So it is not hard and fast that we need to be focusing more on pain and delaying surgery, delaying anything. We should be focused and don't delay time. It is time which saves everything for us. So yes, it is a consideration.
As a matter of fact, I only can talk of myself, and I'm sure all of you would agree. Having a small abscess which is not so painful and patient having sepsis is absolutely not possible. You have to have a certain quantum of infection locally to give rise to sepsis. So I am yet to see a patient who has got a small tiny abscess and he has got sepsis. There has to be another cause.
Has to have some comorbidities behind.
That's right. There has to be. So there has to be a substantial local inflammation and infection to give rise to sepsis.
True. So moving on, in our case, we identified early and drained under local. So the key takeaways for this case would be, need to remember quick SOFA as a tool. Quick SOFA is clinical tool which we can simply put in during our OPD practice as well. Early recognition and early drainage is the key, and conservative is only justifiable when it is by case basis, where it is not sepsis, it is localized collection. So moving on to our case 2, which is a 65-year-old male with type 2 DM and hypertension as comorbid condition, presenting to emergency department with complaints of fever, increasing perianal pain and swelling for 3 days. He reports difficulty in passing stool, rectal fullness and pain on defecation. On physical examination, the patient is febrile, tachycardic and hypotensive. Local examination, he has perianal edema swelling with tenderness around the rectal area. So I would like audience to participate here, because now we have something we have discussed. So going by surviving sepsis, we have lactate which is high. Lactate usually should be below 1. If it is more than 1, it is indicating towards that. So it is 4 in this case with a WBC count of 18,000. And we have resuscitated, started on antibiotics, and patient becomes progressively hypotensive and requiring vasopressor support. So fluid doesn't work. So now moving on, I would like to have audience comment on this. What's the role of imaging in diagnosing? If there is no audience, then I'll move on to our panel, and we need to rule out if there is some complication of diabetes per se, diabetic ketoacidosis. If it is there, we'll manage first diabetic ketoacidosis and then. So the question.
Can I, sorry.
Yes, sir, it's your.
I think that's a very important question. How
Yeah.
can there be no comment on that? I think you ought to do a radiology, and sonography is a part of radiology.
Yeah.
And I think it is time that we encourage and motivate our sonologists to quickly do a transperineal sonography.
Yep.
We have got surgeon who is doing it. Why can't a radiologist do it? Because a simple transperineal sonography, which would not cost you more than 2,000 rupees, can even be done in an ICU bed. And that would give you tremendous. If there is collection, it is done.
It is done.
If there is no collection, then also it is done. That you are happy that there is no
not there.
collection.
Yes. So
Dr. Bhaskar, this here what I would like to suggest that
Yes.
the all whatever is relevant imaging studies,
Yeah.
because you know the imaging might differ.
Yep.
Sir might be having a very experienced ultrasonologist because he is working with him. So
Yes.
he is trained like that.
Okay.
But everywhere you do not get people like that.
Mhm.
And we know the three modalities now and where they work the best.
Okay.
We have the MR, we have the CT,
So
and
we are
have the
coming to
ultrasound.
that, sir. We are coming to that. So now we have imaging, we have three modalities: CT scan, MRI, ultrasound. So now I'd like to ask our panelists one by one, like the question is, what is the role of CT scan in diagnosing?
One comment before
Yeah.
that. No imaging can diagnose the anorectal sepsis. Any imaging can tell whether the patient is heading towards sepsis or not.
It will tell you the
That
anatomically.
imaging cannot be any parameter whether the patient is in sepsis or not.
Yes, clinical picture will dictate, and then you need to go on for things. So the first question about CT scan goes to Dr. Viren, sir. So what do you think the role of CT scan in anorectal sepsis?
Well, if you compare all the three investigations, which ultrasound, CT and MRI,
MRI.
preferably I would do MRI, but regarding CT scan,
Correct.
yes, it's a very important investigation, no doubt about that, because it can tell us the abscess. And not only abscess, it can also tell us the extent of infection,
Yes.
so that we can plan the surgery better, as well as the extent of necrosis if it is there. So I think CT is a very important investigation in this regard of anorectal sepsis.
Yes, sir. Any further comments from about CT scan?
The
Yeah.
CT, further sir will tell, the CT went out of repute as against MRI because you see well all the soft tissues in CT. Whereas when you want to look for a fluid or a pus or a tract, that is
MRI
only
would-
with MRI.
MRI is definitely better. Sir, comments.
I take comment from Dr. Jain and take it further. I think this kind of conference is meant for betterment of the society and betterment of our treatment schedules.
Yes.
Okay, everybody is not blessed like I am with a good sonologist. But then we are talking about where is Swagata. She said that, you know, in their institute, sepsis is tackled in that particular manner, which is...
I will interrupt you. He was never blessed with the sonographies. He has trained and he has taken lot of pains to bring it to this position.
Thank you, Dio. So why can't we all? Now, these are all excellent modalities. But tell me, at what time of a day a patient with sepsis comes to your hospital? Tell me. Out of 10 cases, what
Always.
is... कब आता है?
Emergent time.
रात को आप कौन सोनोलॉजिस्ट आएगा जो आपका सीटी स्कैन कर देगा? कौन इंटेंसिविस्ट होगा जो पेशेंट को सीटी स्कैन मशीन में बैठने को भेज देगा?
क्लिनिकल कंडीशन परमिट करेगा कि नहीं?
No, that's what I say. Clinical assessment, and why not train your sonologist? We are talking to people who have big hospitals, who have good radiologists, who have good microbiologists. You can take a blood culture. Why can't you ask your sonologist to go to bedside and just take a probe and ask Rajiv? He is not a sonologist, but he does it in his theater. Is it so difficult to read? Is it so difficult to say that there is a collection or not? So let us categorize.
Yes.
You see the patient, you start workup. Clinically, you have made your mind say about 70% that this patient has sepsis or collection. You've done a PR and you figured it out. Now is the management. First thing to do is a sonography. Least expensive, non-invasive technique which can be done bedside. Do that, now you know. Okay, CT and MRI to follow, but you have to go as per, because time is most crucial.
Yes.
So that is how you should go.
Yeah. Sir.
Best is so if the facility is available, you go for, and the expert sonologist available, you go for transperineal sonography on the bedside. But if at all you are sending for a CT or MRI, better send for MRI rather than CT.
Sir, I think
MRI
a lot of things
is
are very
more
theoretical here. When you started your slide, you said the patient is on a vasopressor. So when you have patient on a vasopressor, thinking of patient shifting to CT, MR and everything is obsolete. So if you are talking about the patient per se, who's in so severe sepsis with the blood pressure falling, with everything so haywire, diabetic, lot of things are very theoretical. Our approach should be very practical for the patient, individualized. I don't think there is any role for CT scan and MRI in this patient at least. The CT and MR, and to be honest, I have started my own hospital now, so I have got a sonologist. The most important thing is I have started learning ultrasound myself. I did my first ultrasound guided breast biopsy, first ultrasound guided aspiration of the breast cyst and everything. It's very, very easy. Just take it on your hand. Honestly, being a surgeon, we can interpret ultrasound better than any radiologist. I can tell you that. Why? Because we know if we look from this side, where is the gallbladder, what will be the structure around it, what will be the liver, where will be, if I put it like that, where will be the Calyx triangle, I can tell you, it's very easy if you do it on your own. And I've started doing it myself, and I find it very, very interesting. We should learn ourselves do an ultrasound. The most important thing is we can't do it because of this PCP and DT thing. It's very difficult to get all the licenses in place for doing a non-obstetric work. So main drawback might be an ultrasound, access to the ultrasound machine rather than doing the ultrasound.
The most important thing is only surgeon can know what I thought and what it was.
Yes, definitely.
Yes.
Actually, मेरे को पता नहीं आप में से कितने लोगों ने ट्राई किया है. ट्रांसरेक्टल अल्ट्रासाउंड इज़ वेरी इजी और उसके मल्टीपल यूज़ हैं. यूरोलॉजिस्ट भी यूज़ करता है, आप भी कर सकते हो, और इवन आपकी गायनेकोलॉजिस्ट उसी प्रोब को यूज़ करते हैं. इट्स द सेम प्रोब विच इज़ यूज्ड बाय ऑल.
But any radiologist in Bhopal doing the transrectal? Nobody.
और ये सब हम लोग तो डे 1 से कर रहे हैं. हम लोग तो एंडो अल्ट्रासाउंड और ट्रांसरेक्टल डे 1 से करते हैं. हम तो खुद ही करते हैं. हमारे पास तो PNDT है मेरे नाम का. So I am registered in it, huh? From day 1.
I endorse you, but I'd like to make a comment which is very pertinent. अभी आप sepsis की बात कर रहे हो ना, abscess की. You try and put a finger and ask the patient, is it painful or not? And then you try and put a transrectal probe and ask the patient, are you enjoying it? So I would just like to do, I think it is a very good modality when you want to assess the growth. But for sepsis, and transperineal is fantastic when you really want to see the fistula tract, collection and the sphincters. It is very good and least cumbersome to the patient. So I think they all, endorectal and transperineal, have different indications and they can be used even by the surgeons. It's only a matter of taking a license yourself. You can do that.
So, see, we know that imaging is a must. We must know how to do it, and if it is feasible, because PCP and DT does not allow you, but even then you shouldn't report, rather than look at what you are thinking, what you are trying to see, you'll confirm.
Like gynecologists, they can get PCP and DT registered. You have to inform that you are doing the scan. Because I've gone through the rules. You have to inform that you are doing the scan, but as a postgraduate training, you can do. Like gynecologists, they do not need a registration. They मेरे नाम से ही चाहिए. Like radiologists. So इसी तरह से, if you are doing the scan, you have to inform. Like cardiologists, they do for echo. So they are cardiologists. They are not supposed. They are not radiologists. It's a misconception that the radiologist can only can get a license to do an ultrasound scan.
Okay.
Anybody can do it, provided they get a timing. मैं इस वक्त ये करूँगा.
Okay. Yes. So we as an intensivist are using it like from our teaching days when we are trained, we are taught to look at IVC, look at everything through your ultrasound. So it has actually taken the place of stethoscope for us. For this anorectal sepsis, the question was made keeping in mind the students who are at the back who have just been into surgical second year PG. So I'm trying to make them understand that yes, they have definite roles, but we need to choose one amongst the best, looking at the condition, looking at the availability of services at your disposal. So it is not that if I know ultrasound much, I'll definitely use it much, but it is not for others that CT shouldn't be used or MRI shouldn't be used. So this panel discussion was put up in a like keeping people at the back. So moving on.
Sir, I may, Dr. Bhaskar.
Yes, sir. Where's that?
Here.
Like
the case slide which you have shown, BP patient in shock, bulging, superficial erythema and all. If I have ultrasound at my center, can do it. But if I am doing a standalone clinic or a hospital, I may simply aggressively resuscitate by fluid, start antibiotic, and I may go straight away for draining if I cannot do the ultrasound. That is my take on that. Cases like this.
See, you are correct, but it has been repeatedly coming to our frame because I am not a surgical person, but I understand from Dr. Ladda's whatever he said is you need to know the extent of it before going ahead. Definitely role of resuscitation is there. We have resuscitated, we must resuscitate. And then we need to define it more further, looking at what is the extent of it so that I can do it more judiciously and do it more better way. So moving on, I'd like to go for this question, what is the role of MRI in diagnosing anorectal sepsis to Dr. Atul sir?
Hello. Yeah. Very limited for role as sir said, very limited for somebody who has got anorectal sepsis.
Yeah.
Because it's mostly when you have got acute situation.
Yeah.
It's nobody would go for an MRI for looking at the sepsis per se. But yes, if it is a recurrent abscess, if it is something which is happening, if you are suspecting other causes, somebody very atypical in position, where you got multiple problems, because anorectal sepsis mostly starts from cryptograndular tissue infection, which spreads outside, comes out. But there could be other reasons. Somebody has got Crohn's disease, inflammatory bowel disease, tuberculosis, or a lot of reasons. They can also present sometimes with anorectal sepsis. Somebody has had radiotherapy to that area. There are a lot of reasons why somebody can have it. In those complex cases, you might need MR imaging to see the extent of the disease. It's for the possibly knowing the extent of the disease, seeing the surrounding area, rather than the diagnosing the disease per se.
So moving on, yes sir, you have some comment.
Actually, let us forget sepsis, but it is very important for high up collections in the intersymmetric plane, where sometimes the patient is unable to tell anything. He is being treated on the terms of coccydyemia, or you don't feel anything. So you have a gut feeling that something is there, but in routine way or ultrasound or clinically or those cases, those cases they need an MRI.
So now we are coming to ultrasound and its role. I would like Dr. Ladda sir to comment upon what's the use of ultrasound in this particular case.
Let me
because it's so important.
Let me clarify first. We are talking of acute sepsis.
Yes.
We are talking of acute perianal infection.
Vasoactive agents
I
are
think this
in
is
ICU.
This is the first line of investigation that you should undertake. It is least expensive, non-invasive, and can be done bedside.
Yes.
Because the objective is sole, and that is one that whether there is a collection or not. Sepsis you diagnose clinically.
Yes.
But you wish to see if there is a collection whereby it can be effectively drained to give an instant relief to the patient and contain the sepsis. So I think sonography, transperineal I am talking about, should be the first investigation.
Points. Yes, sir. So I hope everyone is clear. Now, to move ahead, my next question would be, summing up the clinical picture, knowing that we have three modalities, where they are important, why they are important. The question is clinical. When should imaging be performed in critically ill patient like this patient which I have described earlier? And the question is to Dr. Chaubal, sir. Yeah, just to endorse the back.
Critically ill patient, you need to act very fast actually. That is why you require a proper information as to what we are dealing with. So as was already mentioned, I am one advocate for POCUS if it is available, like point of care ultrasound. I think if you are managing critically sick patients in your hospital, this is now coming as an essential modality in all critical care setups. You must also be using. And Dr. Ladda has highly emphasized upon that.
Yes.
If you can manage, if the patient is not in shock, and if you really want to have like patient has a history of past rectal abscesses also.
Correct.
You are suspecting fistula, like we manage patients, where we do colonoscopies and all. So many Crohn's disease patients and all. Rectal Crohn's disease, I had a very bad patient with a very severe complex fistula like. So you need to have proper information. What kind of fistula, superficial, intersphincteric, suprasphincteric, whatever it is. You need to have proper. So in that situation where you will require an MRI and probably CT scan, all these things, patient has to relatively stable to undergo that particular. See, MRI is quite a very difficult kind of a situation. Many times I have seen patient dying inside that
MRI scan.
Yes.
So it's about decision should be based on clinical judgment, mainly focusing on hemodynamic stability. If is hemodynamically stable, if time is permitting, then you need to move away from ICU and get it done. Otherwise, ultrasound remains the choice number one for such patients. Moving on, this is a purely surgical question which I can't say, like I will ask Dr. Subodh Varshney to comment. And what are the best practices for achieving source control? This is purely surgical questions. I do not have any say in it.
See,
So
you
it's
have to you have to do early intervention. That's one, as soon as possible, and you have to here cross-sectional imaging or the ultrasound would help you in making sure that there is no undrained pocket of pus which you have left behind, because if you have a ischiorectal abscess, you have drained it well, but still if there is a small extension in the supralevator which you don't know, these are the patients who would not get better and may get worse later. So that's the most important thing. Incision and drainage is a cornerstone, or a drainage somehow, either surgically or radiologically, whichever way, because many times if it is very high, then you won't be able to drain it surgically, then you would like to drain it radiologically. So you have to debride all dead tissue, and as Dr. Ladda said, you have to debride more than less rather. You have to debride more than less, like the cancer, where you always go until the normal margins. And you might have to repeat it, so you have to see every patient differently, and at the end of the procedure, you yourself would know whether you would like to come in again to have a view to further debride it.
Okay, sir. So it is all about managing well, draining early, diagnosing early, debriding repeatedly if required. So moving on.
Can
yes,
I have
sir,
just a brief question from all my surgical colleagues here with the
Sir.
Dr. Ladda, what do you think now is the magnitude of so-called MDROs in these kinds of sepsis, anorectal sepsis, where multi-drug resistant organisms, I think we have encountered that the figures that are now stating for different kinds of infections in India, incidence is to the tune of almost 70%. Yes. Highest incidence of multi-drug resistant organisms are in India now.
Entire world, yeah.
So in your situation, how do you, use those empiric kind of antibiotics in such situations? What all organisms you cover when you are managing the sepsis?
Well, we are talking about perianal sepsis. This discussion is mainly for anorectal infection. We are not touching the colon. So anorectal infection, again, like you said, your scoring or whatever you may call it, we don't know much.
It's just to make it simpler for...
yeah, but we are simple surgeons, we don't understand.
You can
all
just
that.
take it to...
Yeah. So I think coming back to Dr. Chobal's question, as I do it, as I see it, as everybody should do it, is it is extremely important to control the source. That is most important. And for that, recognition and surgery are the mainstay. That is one thing. Two, in our practice, yes, there is a lot of publications about multi-drug resistance. That's right. We have not encountered all that much because I think we are very aggressive in surgically containing the sepsis. In my practice, if there is diabetes or patient has any other coexisting morbidity, and if the sepsis which requires ICU admission, after I have sent all the cultures, which take some time to come back, I would always start them on carbapenem and metronidazole. I may have to add something for gram positive as well, just to cover it, but definitely drain it properly and send the pus culture. I must say I have not regretted this approach significantly, perhaps never, and have not encountered any multi-drug resistant organism.
So the gold standard remains the same here as well, where you need to try to cover everything broadly initially to begin with, and the culture comes, then you de-escalate according to the cultures.
Dr. Santosh,
yes, sir.
There are the two most contaminated area of the body. One is the mouth, oral cavity, and next is the anal canal. And they are getting minimal infections. They are always loaded with the organism. So what is more important is to drain it. Infection is, bacteria remains always there. But my experience is that most of the cases I got the culture sensitivity report resistant to all. But simple IND,
you are not giving any
IND and patient improves well.
Okay.
And to add only one thing, in cases of sepsis and collections and all, when they, sir will agree, when they go for fancy, minimally invasive techniques, there the problem arises where the drainage is not liberal, it is not quite
Sir,
open.
When we say a patient is in sepsis, that time we are saying that it is not a local infection, it has been systemized. It has come to systemic things. So that is sepsis. So in sepsis, like the question posed before was experience of antibiotic, and it is same. It was your experience as well as everyone's experience remains the same. So, sir has some questions.
This time I have a question to Dr. Ladda.
Okay,
And especially, sir, the fungal infection have been one of the important part of the sepsis. So in this part of what today's discussion, what has been your experience about the component of fungal infection in these kinds of the sepsis or infection?
What I have found in my practice is that patients who come directly to me are cryptoglandular sepsis which have gone beyond control, or patient does have diabetes or something like that. Patient who come via my colleague physicians who have been treated for some time, I'll quote a recent patient who I was asked to see bad sepsis covering the whole of the gluteal region and arising from a fistula. It was picked up on sonography, but very bad sepsis already under care of the physician for 15 days and previous history of some surgery done. I was involved into this and I said, okay, he requires surgery. He was stabilized by then after multiple antibiotics, and I again drained and I put a draining seat on because it was very extensive infection, so put a draining seat on, and then the culture grew
fungus.
So I personally feel fungus is a possibility, extremely rare though, and fungus I find to be an opportunistic infection which doesn't affect primarily, but it rides on to prevailing sepsis and causes problems. So I think if the sepsis goes for too long, fungus, antifungal should be given, I feel.
So what we can conclude that long-standing handled cases it is not a bad idea to investigate for fungal infection
I
also.
think we should. I think we should.
Any patient who is on long-standing antibiotic therapy are predisposed to have fungal infection. So that is the other way of looking at the same.
Sir, one more thing. What about your encounter of tuberculosis in perianal abscess?
Yet to see one. It's not so common, Rajiv. It's not so common. I just quote an example, just to justify. 20 years back, I did a total proctocolectomy on a young, dynamic patient who was not even married. He was flown from Calcutta and straight into ICU. Bad ulcerative colitis, and between these four walls, he was being treated by Baba Ramdev. And very strong bhagat of Baba Ramdev, and he was very septic. So we treated him, and then I said, you require surgery. Baba Ramdev ki permission ke bagair nahi hoga. So that was the first and the last time that I spoke to Baba Ramdev on telephone. उसको कार्टिसोन बिल्कुल मत देना. मैंने कहा ठीक है बाबा जी, पर आप इसको ले जाओ, ये मर जाएगा. अरे ऐसा है क्या? ऐसा है क्या? तो ठीक है, फिर आप करिए. He was a relative of a local ENT surgeon. I operated on him 20 years back. 2004 that I operated on him. He did very well, got married, got children. And I just hear from him every now and then. I did not see him for last 6-8 years. Then he rang up once. कि सर मैं इंदौर आना चाहता हूँ आपको दिखाने. मैंने कहा क्या परेशानी है अभिषेक? He said I was enthusiastic, so I undertook some extensive pull-up exercise, and I got pain in the hypogastrium and difficulty in passing urine. I said, what is the sonography? He said sonography doesn't show anything. तो मैंने कहा भाई वहाँ किसी को दिखला ले. मैंने कहा सरफराज बेग को दिखला ले and कर ले. नहीं सर, I'd like to come to Indore. He came to Indore, and to my surprise, he had collection behind the recti muscle, touching the bladder, but no bowel symptoms at all. So I said, there is a collection, I'd like to aspirate. We aspirated, and it grew E. coli. I put him on Farepenem, he got a bit better, so we sent him home. After about 2 weeks he rang back, sir, I got symptoms again, and I'm coming. So he took the evening flight, came back. So we put a pigtail catheter there and drained it. He became all right again. He said, I'll stay here till it gets dry. So it got dry, and we pulled the pigtail out, and I showed it to my physician colleague. I said, look, is there something like tuberculosis here? No other symptom of any kind. Touch wood. Again, I put him on linezolid and sent him away. After 15 days, he did a sonography there and absolutely dry. I was contemplating tuberculosis there, but it wasn't there. In my anorectal practice, I pick up tuberculosis in less than 1% cases, and I always find that there is a rectal mucosal disease along with it. I feel that unless there is a mucosal disease, tuberculosis doesn't just spring just like a cryptoglandular abscess. It has to come from the mucosa, because tuberculosis is basically a mucosal disease. So I have not come across any cases with perianal abscess with tuberculosis.
So moving ahead, this is another.
Is used for MRSA patients. So it's very useful. We should, I think in India we downplay the role of MRSA, but it's very important that we do, because the patient had an operation, has been on antibiotic. So linezolid is a very good effective treatment.
Yes sir.
So यहाँ we have talked lot of investigation, about the investigation, sonography, MRI and CT scan. As Dr. Ladda said, I put the needle. Why we are not talking about the diagnostic aspiration? One the patient admitted in a night in a very big hospital of Bhopal. He does with the fever, and he came to me in the morning without taking discharge, just to show me. I put the needle, I aspirate the pus, means you don't get discharge from that hospital, remains there. I will phone to the surgeon. I phone to the surgeon, means to take care, he is having abscess. So this is why we are forgetting about the diagnostic aspiration.
So we'll moving ahead, as time doesn't permit us to. So I'll just want some short answers on different surgical approach for managing complex I do not know the name of it. If you can, for the backsitters, any approaches, different names.
That's a very difficult question you put in a very small frame. It doesn't have a single answer.
Yes.
And kindly take away fistulas. I think that's a different ball game altogether.
Okay.
Abscesses require proper drainage.
Mhm.
A proper drainage always, people like me who are perhaps more experienced, we look for the source. By that I mean where it sprung from.
Yes.
Try to deal with the source, and in such cases, good drainage and putting a draining seat on is the treatment of choice as far as I am concerned.
Okay, sir. So moving ahead to the third case scenario, I would like PG students to answer, and if you couldn't, then I'll take help of our panel. Are you ready? So look at the case scenario. It's about 72 years female presenting with 4 days of progressive abdominal distension and discomfort. History of hypertension, Parkinson's, and recent hip replacement surgery 2 weeks ago. No prior history of any abdominal surgery or known gastrointestinal disorders. And she reported nausea, vomiting, inability to pass stool gas for the past 48 hours. Looking at this clinical scenario, what comes in your mind, PG students, postgraduates? What comes straight away? Another medication history of significance is she's on opioid for postoperative pain management, antihypertensive, Parkinson's treatment going on. Vital signs are almost stable with a physical examination of some distension and tenderness in abdomen, with no abdominal tenderness and everything seemingly okay. What comes to your mind? We had a discussion prior to my session. No idea? Huh? Yes. So since you diagnosed, so these are something which came up like imaging X-rays with 12 centimeter and more dilatation, as we have discussed in the morning. There was no signs of mechanical obstruction or volvulus or perforation. Normal blood investigation except hypokalemia. So as Dr. Chaubal was mentioning in the prior discussion, that we need to correct electrolyte before moving ahead or before going on for another step. So diagnosis is pseudocolonic obstruction acute, and so I would like to ask what should be the initial management in such cases. I would like to take help of Dr. Chaubal sir to finish. Repeat the things for.
As already mentioned,
yes.
It starts off with a conservative management initially. Slowly rise to aspiration regularly, give TPN also, watch and carefully observe the patient. You need to have repeated X-ray abdomens to see that the colonic, the cecal dimension is not increasing. In case if the patient is not showing signs of any relief, there is no reduction in abdominal distension, then you certainly move the patient to ICU, or where you have under a cardiac monitoring, you can administer IV neostigmine. Doses varied from 1 to 2 milligram, whatever it is, given as in the form of infusion over about half an hour, and check for the sign. Many times the effect is very dramatic, as is mentioned. Within few minutes it may act, or it may take about 30 minutes to act also. Sometimes the patient has shown the partial response, you can repeat the dose of neostigmine again, but after 1.5 to 3 hours, or sometimes even later. So if the patient has definite signs of improvement, and I think 80 to 90% of the patient, they do show improvement, provided you are absolutely sure that there is no mechanical obstruction. I remember this. Yes. This all, we presume that the mechanical obstruction has been completely ruled out. Yes. So that is there. And subsequently, of course, we have to manage the patient. And in case if he is not responding, sometimes the help is taken from gastroenterologist to do colonic decompression, which we have done in some cases. In certain mechanical obstructions like volvulus also, we use colonoscopy for derotation, all these things that we have done. In this situation also, simply aspirating all the air can sometimes result in this thing, and sometimes we can put this tube also for decompression up to 7, just as I have already mentioned.
Okay. So, as we have discussed since morning, this is the second time we are touching upon pseudo obstruction. So, we know that role of decompression is when our medical management fails, and since our patient was has responded to neostigmine, so thank you. Thank you.
Thank you.
Thank you, Dr. Santosh, for conducting this panel discussion, and we are thankful to all the panelists. I will request Dr. Abhijit Deshmukh. Dr. Abhijit Deshmukh is a GI and laparoscopic surgeon, as well as he is holding the post of BJP Chikitsa Prakost Adhyaksh. Please come forward and give a moment to all our panelists as well as the speakers. हाँ सर, हाँ ठीक है। Now this is the time for all our postgraduates, and we have incorporated a PZ quiz which will be conducted by Chirag and myself, and I will request Dr. Chirag, please come forward and do all the necessary arrangements, and that is on Mentimeter, na? Yes. This is on Mentimeter, and we have to just open our mobile, and it is going to be a very interesting, and we have kept certain prizes, first, second, third, and all the 6 teams are here. 3 teams are there. So at present we are having the 4 teams from 4 different medical colleges.
Good afternoon, everyone. I request all the teams to come forward. A team from People's Medical College, please come ahead. From RKDF Medical College, Chirayu.
Now, to conduct this session, we have invited Dr. Manish Badkur. Dr. Manish Badkur is a chief intensivist in one of the corporate hospital of Bhopal. He is, yes, Dr. Manish is here, and Dr. Manish and Dr. Chirag, they are going to conduct this quiz. I will request all the team members of different medical college, please come forward. And in fact, this quiz is open for everyone. Those who are watching all of us, an entire event on YouTube, they can also participate in this quiz.
Five teams for quiz: LNMC, RKDF, GMC Bhopal, People's, and Chirayu Medical College. Is there anyone else? Any other team? So we have 5 teams for quiz competition. The rules for quiz competitions.
So all the teams are ready. So first is People's, second is RKDF, third is GMC, fourth is Chirayu. Chirayu, okay, done. So what we have to keep in mind, the first thing is that we have to answer fast. So as fast we answer, we will get more points. So we are just running a trial quiz, as many of the audience wanted that we should go with the trial quiz. So we are beginning with the trial quiz. So what you need to do, you need to just log into menti.com or log into menti.com. Go to your mobile browser, you can just go to menti.com, menti.com. You can put this code which will be displaying on the screen, that is 1376. Switch. Yes, you can also scan the QR code also if required from your mobile if you are unable to log in. So everybody has reached to the menti.com? Or you can just scan this barcode, you will be able to just directly go to the link. And after going to the menti.com, please enter the code which is displayed on the top, that is 13763709. Yes, sir, the same green page. So everybody has got to the green page? Please come ahead, अगर कोई problem है तो please आप आगे आइए. So shall we start? And everybody has put in the this login code. Please enter your college's name. So we are beginning with this presentation now. So again now the same thing which we need to do. We need to enter fast to get more points. So everybody is able to see. So we have 9 players, now we have 10 players ready. So first page tha, first page. I'll go back. Has all team connected? Please raise your hands अगर किसी को कुछ problem आ रही है तो. Yes, please put your college name. So this is a trial quiz for 5 questions, then we will move to the main quiz ahead. Shall we proceed? Everyone is ready? Yes, this is the trial quiz, sir. Sir, so we are beginning. So we have now 10 players, 11. Are you on? Done. So again, remember to answer fast to get more points. So next instructional course of Acrsi 2025 is at, the answers on your screen is Delhi, Chennai, Bhopal and Ahmedabad. So this was displayed many times on our screen before we had to start the conference. And let's see. Okay. So 8 people were correct in this. So I'll not display the wrong people's name in this list. So let's see the result. Who has given the correct one? Okay, so PCMS was the fastest and the second is GMC and then third is the Chirayu. Let's go to the next question. From which college, ma'am? Ma'am, list में नीचे होगा आपका कहीं. If you must be back then. So full form of Acrsi is like Association of Rectal Surgeons of India or Association of Colon and Rectal Surgeons of India. So everybody has answered, I guess, till now. Okay, everybody was correct out of it, like. Okay, so the MC was not the MC is the fastest in this, I guess. Okay, good. Annual conference of Acrsi 2024 was at. The options are Mumbai, Delhi, Chennai and Ahmedabad. So 8 people have answered, 9, good. 11 have answered. Oh, so only 4 people were correct in this. Okay, so Chirayu is the fastest in this now. And who is Maverick? Kindly raise your hand, please. Okay, it must be then somebody online. So we are having this online also. Many people from all over the India are also online with the quiz. So next Acrsi annual conference will be at Bhopal, Chennai, Ahmedabad and Lucknow. So you can give a thumbs up if you must have done by now in this. Only one person was correct out of it. किसने कहा डाला था सही आंसर किसका है? Okay, so Chirayu was the winner in this our trial quiz. So now we will be moving to the final quiz. Sir, yes sir. I'll be there. मैं एक बार आके So we are beginning with the final quiz. I request Rajiv sir and Santosh sir to be just to be next by us. So all teams are ready and shall we proceed? So. I guess now it must have been displayed on your screens of your mobile. Mobile में change हो गया सबके? किसके कुछ problem किसी के आपके हो गया change? You have joined? Connection थोड़ा भी slow होगा तो might face some problem. So we all are ready, so we shall be proceeding now. Okay, so let's see how many players are ready. We have like 12. Okay, only 12 players are ready with us right now. So again, remember to answer fast to get more points. So are we all PSC fit right now? So we have like fit, unfit, and we have review with the reports. So 14 people have answered. Okay, so one is unfit, like, and 2 people are review with the reports. Good. So you are losing your points then. So it will, if you must have answered fast, your name will certainly come in this. Okay, 17 players are ready. So what is the most common symptom of colorectal cancer? It's abdominal pain, rectal bleeding, weight gain and nausea. Oh, so 14 people were correct and 1 were wrong. हाँ, यहाँ वाले एक भी नहीं है. Okay, so Dr. Centipede, यहाँ कोई है present है? So GMC is centipede. Okay. Name one diagnostic tech used for colorectal cancer. It's colonoscopy, CT scan, MRI, or none of these. So everyone is correct. Good. So who was the fastest in this? So again, GMC is on the top. Good. And Sakura. Can Sakura please raise his or her hand? Like. Sir, नहीं सिर्फ first 10 का आएगा. So which of the following is a risk factor for colorectal cancer? High fiber diet, family history of colorectal cancer, regular exercise and low fat diet. So 14 people were corrected. Good. So GMC is again on the top. Chirayu, you should boost up. And PCMS कहीं पे भी नहीं है बीच में. So what is the most common cause of post-operative ileus following colorectal surgery? Electrolyte imbalance, prolonged anesthesia, opioid use, or surgical site infections? So 3 people were correct in this. Okay, so can Tom raise his hand, please? Oh, so Tom is which medical college? LN Medical College. And Namrata Pandey was the fastest in this. Can Namrata Pandey please raise her hand? Good. So which stage of colorectal cancer is characterized by metastasis? 1, 2, 3 and 4. This should be the fastest answer, I guess. Sixteen people have answered by now. 11 were correct in them. Okay, so GMC was the fastest to answer this question. Good. Which measure is the most effective in reducing post-operative pulmonary complications in colorectal surgical patients? Prolonged intubation, early extubation and respiratory physiotherapy, continuous monitoring of oxygen saturation and routine tracheostomy. So everyone have answered, good. So 15 were correct, good. So again, GMC was the fastest. So clap for GMC, I will say. So what is the best approach to prevent deep vein thrombosis in high-risk colorectal patients? Prophylactic anticoagulation, compression stockings, early ambulation, or all the above? So yes, 7 people were correct in this, all the above. Okay, so like cake and anidroid. So if anyone here, please raise your hand. Okay, so which college? Chirayu, good. You are cake and anidroid. So I had previously requested, please put your college names. That will be the best part. So which electrolyte imbalance is the most commonly seen after prolonged colorectal surgery? Hyponatremia, hyperkalemia, hypokalemia, and hypernatremia. Good. So 14 people were correct in this. So let's see the result. So GMC was the fastest in this. Good. What is the most common complication after colorectal surgery requiring an ICU care? Pulmonary embolism, anastomotic leak, acute kidney injury, or wound dehiscence? Good. So who is now Snuggles? Please raise your hand. Good. I request Manish sir to come forward and put the game. Please remember to answer fast.
In managing fluid resuscitation for a septic colorectal patient, which type of fluid is preferred initially? Hypertonic saline, crystalloids, albumin, blood products. All are correct. So fastest is Tom.
Tom, please raise your hand. Like Helen Middle.
Yeah.
Yes, Nagas ma'am.
business selfie. Which vasoactive drug is commonly used to manage septic shock in post-operative colorectal patients? Dopamine, epinephrine, norepinephrine, dobutamine. Yeah, very good. At least 10 people could correct norepinephrine. So in septic shock, the vasopressor choice is always norepinephrine. So Chirayu is the fastest, and now the leading team is GMC. Okay. Anidroid we are not able to find out who is on second in point tally. And Snuggle is, I think, sir. What is the recommended target mean arterial pressure for septic colorectal surgery patient receiving vasopressors? 50 millimeter mercury, 60 millimeter mercury, 65 and 75. It is 65 millimeter of mercury. So GMC is fastest and highest in the point tally so far. Good.
So we will go with the third. Who is Simba?
Anyone? Simba? Which of the following is a contraindication to enteral feeding in a critically ill colorectal surgery patient? Paralytic ileus, nasogastric tube in place, mild nausea, post-operative day 1. Good. Paralytic ileus. So fastest is anidroid. Okay. What is the best method for assessing fluid responsiveness in critically ill colorectal patients? CVP, passive leg raise test, pulmonary arterial catheterization, and arterial blood gas analysis. So answer is passive leg raise test. It is a commonest bedside test which you can do with minimal invasive monitoring, and CVP is a static parameter of checking the fluid responsiveness, but nowadays the dynamic parameter like passive leg raise test is giving more accurate value for the assessing fluid responsiveness. Which nutritional support method is preferred in critically ill post-operative colorectal patients who cannot take oral nutrition? Total parenteral nutrition, enteral nutrition via nasogastric tube, peripheral parenteral nutrition, and oral nutritional supplements. Spontaneously आ गया. Fastest is Namrata. Good. Next. What is the most common causative organism of anorectal abscess in immunocompetent individuals? First is Staphylococcus aureus, E. coli, bacteroid species, and Streptococcus pyogenes. Only 3 were correct. Bacteroid species. Snuggle is fastest. Good. Next. Enhanced recovery after surgery protocol in CRS aims to reduce post-operative complications. Which of the following is not a component of ERAS? Early mobilization, prolonged fasting before surgery, early oral feeding, minimizing opioid use. Very good. 14 were correct. Fastest is Chirayu this time. What is the first line antibiotic therapy recommended for patient with toxic megacolon secondary to Clostridium difficile colitis? Metronidazole, vancomycin, ciprofloxacin, amoxicillin. So answer is vancomycin. Actually, vancomycin can be given orally as well as perrectally. Once the oral route is not used, then perrectal vancomycin can be used along with the metronidazole. Good, GMC is now topping up. Fournier gangrene, a form of necrotizing fasciitis affecting the perineum and genitalia, is most often associated with which predisposing condition? Diabetes mellitus, hypertension, CKD, Crohn's disease.
Yeah. So 16 people were correct in this. So we have like 3 people on top. GMC is on the top, Sir is on the second, and third is Cake is which college? Ellen. चिरायू मिडिल कॉलेज. ओके. चिरायू में एक और लॉगिन है जिसमें फास्टेस्ट है तो ओके. Remember to answer fast to get more points. So in a critically ill patient with a septic shock secondary to a perforated clonic diverticulitis, which resuscitation endpoint is most closely monitored? Serum lactate levels, blood pressure, arterial blood gases, and CVP. Three people remaining, two. Good. So 7 people have answered the correct, that is serum lactate level. Okay. What is the standard procedure for preventing anastomotic leakage after a low anterior resection? So the options are use of tissue sealants, diverting loop ileostomy, and early feeding. Delete the option 4, please. Good. So all were correct in this. Let's see who was the fastest in this. Android, please raise your hand if present here. Which condition often requires early interdisciplinary coordination between the colorectal surgeons and the intensivists? Diverticulitis with a small abscess, perforated colon with sepsis, hemorrhoids, or an anal fissure. Okay, 13 people were right with perforated colon and with sepsis. Good. So Chirayu is again on the top, 16,787 points. अच्छा सर आगे स्नगल अच्छा So what scoring system is commonly used to assess the severity of sepsis in colorectal surgical patients? So we have already discussed like SOFA score, GCS, Ranson criteria, and Apache 2 score. So in this, people have answered Ranson criteria also. So sir is on the top again. A clap for sir, please. And Chirayu is fastest. So what is the optimal timing for administering preoperative antibiotics in a colorectal surgery? It's immediately after the skin closure, 30 minutes to 1 hour before the incision, during the bowel preparation, or 6 hours after the surgery. Okay, 15 people were correct. Okay, sir is on the top, and again this time Chirayu is the fastest. I think GMC should boost up now. Which ventilative strategy is preferred for a colorectal patient with acute respiratory distress syndrome in the ICU? A high tidal volume, low tidal volume with high PEEP, zero end expiratory pressure, and zero end expiratory pressure. Again, it was the same. Yes, good. It's 15 people have answered it correctly. That's nice. So this time Android maybe like online and is the fastest person. Which of the following is a key indicator for transferring a colorectal surgical patient to ICU post-operatively. Tachycardia with fever, significant intraoperative blood loss, delayed bowel movement or mild post-operative pain. This should be like the fastest answer. Okay, so 2 people were correct. Let's see who were them. GMC was one of them. And the fastest. So GMC is now on the top. Which of the following is considered to be a red flag for the development of an intra-abdominal sepsis following colorectal surgery? Persistent low-grade fever, leukocytosis and hypotension, an increase in the bowel sounds and mild abdominal pain. Read the question again, red flag. Yes, 16 people were correct, good. So sir is on the top with 19,559 points, good. And GMC is 19,323 points. Okay, so everybody's ready with this question? Name which block? See the diagram properly. Posterior perineal block, sacral block or a caudal block? Okay, so 12 people were correct. Yes, good. So GMC was the fastest, good. Second is sir. Now GMC is 20,272 points and sir is 19,559 points. And Chirayu is on the third. Last 2 questions remaining. In which colorectal surgery caudal block should be avoided? Read the question again. The correct is like panoidal sinus, fissure, hemorrhoid and fistula, not an extensive one. You have 4 options. Fourteen people have answered, 4 people again remaining, 15. Good, 12 were correct. So GMC is leading the lead like 21,173 points. Good. Contraindications as for caudal block are except neurological diseases, coagulopathy, skin infection in the area of indented puncture or diabetes. So 10 were right, good. Sebastian. Who is Sebastian here is present here? So Sebastian was the fastest to answer, that's good. He must be online, yes sir. Yes sir, yes sir. Again the same question. And this is the last question. Name this block. Spinal, caudal, epidural or none of these? Good. So 14 were right. So let's see the final result. I request Rajiv sir and Santosh sir to please come here. Yes, sir. Yes, sir. Yes, sir. Yes, sir. So centipede is GMC is on the top.
Thank you all the participants from different medical colleges. And in fact, this quiz was participated by many delegates, those who were attending this entire program through online YouTube channel. And I will request Dr. Chirag to declare the results.
Yes, sir. So like Dr. Centipede is GMC. So first is the GMC.
First, online as well as offline.
Yes, sir. Online.
So Dr. Centipede is... Acha, it's a GMC team. Okay, okay, that's good. So the first prize goes to GMC team. I will request Dr. Abhijit Deshmukh, please come forward and give a first prize to GMC. I was confused because they have written centipede. So it's a basically team from Gandhi Medical College, Bhopal. Okay. Please come forward. Now I will request Dr. D.U. Pathak, please come forward to give the prize. And the second prize goes to?
Sir, it is mentioned Snuggles, so I request. नहीं सर आपसे
ऑनलाइन में ये नहीं कहा था
हाँ सर yes sir was
so second prize goes to Dr. Navneet Mishra from Bhopal. I will request Dr. D.U. Pathak, please sir.
Cake. So third is Cake and he's from Chirayu Medical College. I request him to please be
I will request Dr. S.K. Nigam, please come forward to give the third prize. Now we are keeping the consolation prizes to other medical colleges team.
So I request like People's Medical College to please come on the stage. Chirayu Medical College, please. Aye. वो कौन सा था? चिरायू नहीं एलन पीपल हो गया एलन मेडिकल कॉलेज प्लीज RKDF Medical College, please be on the stage. Yes, sir. Yes, sir. Last, RKDF Medical College. I request all the medical colleges team to come on the stage for a photograph.
We want to take a photograph for all the participants. Please come forward.
Please.
Yes. Please. Thank you. Please come forward. All the teams, सबके जो भी head कर रहे हैं, ठीक है, चिराग, मनीष, please come forward. सबको team wise सबको दे दीजिए. Come forward. Team head. पहली team RKDF.
I request Santosh sir to please come.
Santosh sir. He's not here.
Come forward next team. This is Chirayu Medical College. Next team RKDF.
ये लोग अभी 2 दिन पहले ACLS सीखे मेरे.
I request Rajiv sir to please come and give it to PMC.
Yes. Congratulations.
Please come. Team.
सब लोग I will request all the participants, please take a seat. Still we are having a one short presentation by Dr. Santosh Bhaskar. He is going to take us regarding the use of
Farepenem. Sirf Farepenem.
So use of Farepenem in anorectal wound infection.
चेंजर दे दो वहीं से चल जाएगा बस 7 स्लाइड है चलो this is just to conclude. How many of you have used Farepenem in your clinical practice? No one. One person. So I have 7 slides for Farepenem, and it is not company made, it's my own presentation, so it would be like what I have understood as for Farepenem. So what is Farepenem? The first question is, many of us confuse it with Carbapenem, and Carbapenem is something else. It is simply a penem, and penem is structurally similar to Carbapenem. How they are different is one bond that makes it different. In place of sulfur, carbon is replaced, so they are called as Carbapenem. But Carbapenem are very resistant to antibiotics. They are more potent because of structural differences. Though people think it is Carbapenem and they switch from IV Carbapenem to oral formulation, considering it to be the same, but it's not same. Next slide. How Carbapenem works is as a beta-lactam antibiotic. Any beta-lactam antibiotics works on cellular wall, and it works the similar way. Spectrum is quite wide. It covers gram-positive, gram-negative, as well as anaerobes. And if you know that why cephalosporin has gone into disrepute is because cephalosporins are broken by beta-lactamases. Those beta-lactamases are known as ESBL, extended spectrum beta-lactamase. But Farepenem is resistant to many of the ESBLs. Hence, it's better. It's better than simply amoxicillin or anything of such order. It has resistance towards like beta-lactamase. It won't be hydrolyzed easily as amoxicillin would be. It's more effective against common pathogens, useful in respiratory tract infection. In India, or if you see the world data, it's primarily used in pediatrics. Pediatricians are very fond of this, but this as a molecule is an oral formulation which we can use in our clinical practice. Though there has been trial of Farepenem for sinusitis, skin and soft tissue, community-acquired pneumonia, but because of some fallacy in the trial, FDA has never recognized it as a molecule of such strength because of trial design failure. It's orally available, rapidly absorbable, bioavailability is good, and primarily is excreted through kidney. So key takeaways are, it's not carbapenem, it's a penem which has its use in respiratory tract infection, sinusitis, skin and soft tissue infection, and it is safe as well as efficacious. So if you try to find out more about Farepenem, if you try to PubMed the question, you'll find none. Why? Because this molecule was formulated by Japanese, and whatever literature you find on PubMed are mostly English. So Japanese literatures are not widely prevalent or widely distributed. So this Farepenem as a molecule, we'll know less of it because it's a Japanese molecule formulated there, used there. So whatever data we have is actually we are taking from Japan. Right? So thank you very much.
Just a minute. Now, I will request Dr. Dew Pathak please come forward and present a memento to Dr. Manish Barkur as well as Dr. Chirag. They have conducted this PG quiz very nicely. वो पीछे पीछे नीचे. Yes. Dr. Manish, please.
Thank you.
Thank you, Kiran. And now this is the time to conclude our session, but before concluding our this event, I will request Dr. Dew Pathak to say a few words regarding today's conclave on colorectal critical care.
My dear friends, this is a sweet responsibility given to me. It is like serving a dessert after a good lunch or dinner. And I really wonder, why didn't this thing happen earlier? Because day in and out, we are thinking of what antibiotic to give, what preparations to make, whether this patient is okay or not. And believe me, I confess, I also am shy to say that I never knew of SOFA before. And it was good of Bhaskar कि उसने माइक मेरे हाथ में नहीं दे दिया कि व्हाट इज़ योर से, और गलती से या प्लान वे में चौवल साहब के हाथ में दिया. दैट वाज गुड ऑफ यू. एंड पहली बार संतोष से मिला. आई एम हाईली इम्प्रेस्ड. एंड संतोष और इन्होंने जो मिशन लिया है हाथ में, इट्स अ मिशन. बिकॉज सर्जरी के वर्कशॉप्स बहुत होते हैं, सर्जरी की टीचिंग्स बहुत होती हैं, बट दिस वाज अ वेरी यूनिक एंड डिफरेंट थिंग which should be repeated in all the national conferences related to colorectal surgery. And that gave me an idea in which to suspect, which patient to avoid, which patient to refer. And it gave me a strong message that to deal the critical patients is not matter of giving antibiotics by common sense. It is a different piece of cake, and you should hand over the patient to the intensivist. And a message for physicians and intensivists also. Of course, you people come later into picture, that the source should be drained. Sometimes the physician keeps on treating, that's a bad thing. And sometimes we surgeons keep on treating, that is also bad. So it's a teamwork. And राजीव, थैंक यू, सबको इन्वॉल्व किया इसमें. And this whole team should go on a national platform also in all forthcoming conferences. And that's all. So nice, thank you. It was a pleasure coming.
And now this is the time to conclude this session, and it's time to give vote of thanks to everyone. I am thankful to all the seniors, those who have come across the Bhopal. I am thankful to Dr. D.U. Pathak, Dr. S.K. Nigam, Dr. Ashok Ladda. I am thankful to the entire team of Acrsi, Association of Colorectal Surgeons of India, from President, Secretary to all the executive members of different zones. I am thankful to all the viewers, those who have watched this entire program through YouTube. And although it was a very offbeat program, because it was never heard in any scientific conferences regarding the surgeons, they were talking about the infection. So especially I am very much thankful to only one person, that is Dr. Santosh Bhaskar, who has helped me a lot to prepare this entire program. I am thankful to the pharmaceutical company, Sun Pharmaceutical Company. They have come up, and with their support we could able to organize such type of events. And lastly, I am thankful to our audio video persons, and they have conducted this entire program very nicely and very sincerely also. So thanks again to all of you. Thank you very much.